All right, everyone, thank you for coming. We'll get started in just a minute. We'll just give a few more people a chance to join. But we're going to start with gastro and GI surge this morning. All right, so we'll get started in just a second, but today's outline is we're going to start with gastro and surge, and then hem and onc, endorenal, have a quick break for lunch, and then I'll take you through some derm, ID, and genetics. And if we have some time at the end, then we'll go through some questions as well, slash any other questions that you guys have. I'll just start off by introducing Molly, who's going to take us through gastro. Thanks, Molly.
Yeah, okay, I'll share my screen. And please let me know if it's the presenter view before I start presenting, because I find that so annoying when people present the whole time. Is that the right view? Yes, great. Okay, so as Namik said, we're going to be running through some gastro this morning. I'm not covering any surge topics, so if we happen to miss one between the two of us, let me know and I can add some more slides in afterwards. Obviously today is a pretty solemn day for a lot of people, so I did want to pay my respects to Aboriginal elders and First Nations people joining us today and watching this recording later. Today I'm on Wurundjeri land of the Kulin Nation, and pay my respects to elders past and present. So our topics this morning, I'm doing all of the matrix gastro conditions, plus a couple that I've added in that I think are really important, but either aren't specifically on the matrix or are kind of lost in other matrix conditions. Everything that I talk about is basically from the RCH guideline. So if you have any questions, go there first, but otherwise I included my email on the first slide if you want to reach out. So firstly, dehydration. It's not specifically in the matrix, but it is really quite important and it is fair game for questions. The other thing I'll say is I highlight things that are very Monash specific or important for your exams in pink. And a few things that are grayed out just means I never knew them for my exam, so you probably don't need to either. So firstly, the assessment of dehydration. So we want to do this basically for any kid, but especially for the gastro conditions. And it's pretty simple. You want to know their intake, so anything food and fluid. And most importantly, we want to compare that to what is normal for that specific child. And then output as well, so the normal things like urine and stool, but also thinking about excessive losses. So vomiting, diarrhea, sweating in febrile kids. And of course, we need to know the classic question, if they're wearing nappies, how many wet nappies and what's the normal number is a really great assessment of dehydration. Our exam, it's a classic fluid balance exam with a few extra things. So something that's really important at Monash is, and just for peds, is that if a child has a decreased conscious state, so lethargy, then we're really worried. So have that as a red flag symptom in your mind. And of course, the thing that's going to be different for little babies is their fontanelles. So checking that the fontanelles are not sunken. The other thing I've noted in red down the bottom here is skin color, temperature, and peripheral pulses do not change until you have shock, essentially. So if you have any of these things, you are extremely worried and you are acting immediately. Yes, okay. And this is the dehydration chart from RCH. I don't think you need to remember it specifically, but knowing that these things highlighted in red are shock, and that basically any other change from normal is moderate. So how do we rehydrate babies and children? Obviously, with all people, we ideally rehydrate people orally if we can. So we're doing this with oral rehydration solutions, so like Hydrolyte, or if they're still breastfeeding or formula fed, increasing the amount of normal, which basically just means like offering the breast more, offering bottles more, or if they're drinking water, obviously increasing their water. Highlighted in grey here is you should cease fortified feeding. Essentially can impact dehydration and electrolyte status, but I didn't know it for my exam, so neither do you. Then, of course, any child that is not able to increase oral fluid, then we move to NGT. So again, it's the same actual methods, like the same actual fluids that we try to give as oral, but we're just giving it through an NGT. Now, IV fluid therapy is reserved for really, really sick patients. And so it is not usually your first line, but it's important to note what we give when someone is getting IV fluids. This is probably fair game in your exam. So, and you can kind of think of it as sort of a step up method. So the first thing you'll ever do if someone's dehydrated is you'll give them a bolus. And that's just your plain sodium chloride. So you're just trying to fill them up with fluid as quickly as you can. Then if we're giving maintenance fluids, we're also adding in a little bit of glucose to that solution because obviously they're not going to be eating normally and you need sugar to function. And then if they have gastrointestinal losses, it's that same fluid, but we're also adding potassium. So as I kind of mentioned there, the formula is for giving any fluids is first you want to resus them if we need to, so that's boluses. But then we're working out what do they need as a maintenance amount of fluids, and then we're replacing any additional losses mil for mil. The other thing is, and is like extra points if you still have OSCEs, you want to be reassessing them if they're getting fluids. You want to be doing that at least every 6 hours, but more rapidly if they're getting IV. And it's something that you must know is that in respiratory and CNS infections, you give maintenance fluids at 2/3 of the normal rate because in these conditions, you get an increased ADH secretion. So the kids are holding on to more water than they would otherwise. So if you give them too much, you might overload them. In terms of the rates, oral, you're just offering it really more than normal and as much as you can. There is specifically for gastro, you give like gastroenteritis, you give 10 mils per kilogram per hour, but I don't think anyone is really calculating that and giving that to a child. You're just trying to rehydrate them as quickly as possible. However, for nasogastric fluids and IV fluids, there is a bit of a rule. So for maintenance, it's the 4-2-1 rule. I think it is worth remembering this for your exams. I'm not going to read it out to you, but you can use these slides and remember this because they have asked questions asking you to calculate this in the past. Replacement after that is supposed to be mil for mil. So you have a strict fluid balance chart for anyone who's losing fluids or you're worried about dehydration, and you're calculating the mil for mil losses. Also, apologies. I know there's some spelling mistakes in here, but when I was going back through, I couldn't find them. So apologies for that in advance. And then if you have to only remember one calculation for your exams, I recommend knowing the resus bolus calculation. So it is 10 to 20 mils per kilogram of just sodium chloride. And you are reassessing immediately after you give that. Again, for IV, I believe that the maintenance is the 4-2-1 rule again. And gastrointestinal losses, again, replace mil for mil, and that's over the time period they've lost it. So if they lose 200 mils in 4 hours, we're giving them an additional 50 mils per hour. Okay, so a first MCQ. Type in the chat if you have an answer, and I'll wait for just a moment. But for a child who weighs 15 kilograms, which of the volumes below is the most appropriate fluid rate or amount? And I've included this because it's kind of a Monash way of asking this question as well. So essentially, the formula is 10 to 20 milliliters per kilogram. Most of the time you're giving the 20 milliliters because unless they have a condition where they can't tolerate as much fluid, but that almost never happens in Monash world. However, they haven't given you an answer for 20 mils per kilogram, so the answer is 150 mil, which everyone got right. Okay, so gastroenteritis, again, an R1 to me only, but I would definitely put money on it being in your exam in some way. It's probably, if it's better into like viral infections in infectious diseases in R2, but I don't think that gives it enough credit. So gastro, it's obviously vomiting, diarrhea, fever, and in children, they'll get reduced activity. The money for these questions is that they'll have sick contacts or they'll have a higher risk exposure, like being at daycare or school. On examination, they may look fine. They might have some abdo tenderness and they might be a bit dehydrated. But the question that has come up in the previous years is, what is the bug that causes it? So norovirus is the most common cause of gastroenteritis. However, if they don't give you that, rotavirus is the most common cause of gastro in children outside of noro. And it's really common in like daycare centers and things like that. I've included some red flag symptoms here for gastro. So essentially, if they have any of these things, they're either really sick or you have a different problem. But I won't go through that now. The other money for gastro questions is that gastro is a clinical diagnosis only. You don't need to do any tests, especially in kids. There are exceptions, obviously, if they're unwell for more than 10 days, or if they're really, really sick, or they've got some other comorbidity, then we're obviously going to do some testing. But in Monash questions, it's almost never that situation. If it was to be that, you would think about doing some blood sugars, ketones, a UEC for renal function if they're really dehydrated, and you would get a stool culture or a viral PCR if they have bloody diarrhea, if they're a return traveller with more than 10 days of symptoms, or if they're immunocompromised with a fever. So the management for this is oral rehydration, where especially in this, we're rehydrating them as quickly as we can, because essentially we know that gastro is self-limiting. We know that they'll get better, and we kind of just want to get them out of hospital before they get an infection in the hospital. You can give on-dance to kids who are over 6 months old, and especially you would give that if they have an NGT, but otherwise we don't do anything. And some really important things to remember, which they might ask you to catch you at, is we don't give any other antiemetics because they're not safe for children We never give antidiarrheals in children and adults. We don't really give probiotics, not because they're bad, but just because there's no evidence for them actually helping. And we do not give antibiotics to viral infections. That is something that Monash will always try and trick you on. So another thing that does come up is perianal cellulitis. So this is a complication of gastro or constipation. And the Monash question is, that has been asked many, many times, is that you get a child and they have a well-circumscribed, erythematous, painful or itchy perianal lesion. The management for this is we swab it because we want to confirm that is what we want to confirm the bug. It's usually group A strep. But before we even get those results, we're treating it empirically. I have included this here because in all of the practice exams, the treatment is oral penicillin. However, looking at the guidelines, it doesn't seem like that is actually the current management. So because it's usually strep pyogenes, is susceptible to penicillin, but it can actually recur if we treat it with penicillin. So usually now we use cefalexin. But if in your exam cefalexin is not an option, then you're using penicillin, absolutely. And if they have an allergy, you use clindamycin or Bactrim, which is trimethoprim sulfamethoxazole, just in case they try and trick you on that question with multiple answers. But moving on, so we have a 2-year-old boy with problematic constipation, and he's noted to have a well-circumscribed patch of erythema around his anus. The senior colleague thinks it's a strep infection. What are we treating it with? Which I've just said, so you should hopefully get it. I'll give you a second. Okay, perfect. We're treating it with cefalexin unless it's using the old information and then we're picking penicillin. So another really important condition, which is in the gastro matrix, is reflux. So essentially the way Monash will test you on this is they will trying to be getting you to look for, is this gastroesophageal reflux or is this GORD? So is it normal or is it pathological? So GOR, without the D, is just the effortless passage of gastric contents through the esophagus. So we all have seen probably babies spit up. They do it all the time. It's really normal. And it occurs in healthy babies several times a day and affects 40% of babies, this specific GOR. The diagnosis is clinical, but it can help for clinicians to observe a feed. Probably not something you really need to know for your exams, just that we don't test it. But the important thing is for parents, so the management is counselling and reassurance. So where GOR starts before the baby is 8 weeks old, it peaks at 4 months, and it usually resolves by 1 year. Now, if they have this effortless vomiting, but they also have a refusal to feed, irritability with feeding, aspiration, or highlighted in pink here, which I think is the Monash buzzword, a chronic cough with or without wheeze, any slow weight gain, hematemesis, basically anything pathological, then this is GORD, not GOR. So going back a bit, again, reassurance and support is the main thing. If you got this in an OSCE, this is the management. So like adults, you don't lie down after eating, you sit them up. But an important thing is you don't let them fall asleep sitting up unless you're looking at them in your arm, because there is a high risk of SIDS. You can give thickened feeds and essentially just refer them to a maternal child health nurse. This is not as important as just its reassurance. Now, GORD. So again, the symptoms are here. So it's any of that effortless vomiting plus these pathological signs. One of the important things you have to do with GORD is you must rule out a cow's milk protein allergy, which we'll talk about later, because 40% of children presenting with the symptoms of GORD actually have CMPA. So we don't investigate because, again, we really try to do clinical diagnosis in peds, but also there's nothing that's actually diagnostic to prove this. So our management is acid suppression. So a 4-week trial of omeprazole. We counsel the parents that it'll take 4 days to actually reach its maximum effect. And something that I've seen in the questions before is the, I guess, side effects of babies and children on PPIs. So I'm pretty sure the question that I saw was that they're at a higher increased risk of community-acquired pneumonia. They're also at a high risk of gastro, and then long-term, they're at a risk of fractures and micronutrient deficiencies. But really knowing that this can cause or make them more vulnerable to pneumonia and gastro is something that you probably should know. At 4 weeks, if you haven't seen any benefit, then we're stopping therapy. You can also give surface agents, so Gaviscon, but you can't use it for a long time, and it reduces visible regurgitation. So it's not necessarily going to reduce the irritability, which is often some of the most like anxiety inducing symptoms for parents. And then if they have intractable unresponsive GORD, then they're going for surgery, but this just never really comes up in your exams. Okay, so we have a baby who's presented at 3 weeks of age with a history of vomiting from birth, which was an uncomplicated vaginal delivery at term. The vomiting is effortless and mostly after feeding. The baby's rest rate, pulse rate, body temp, all normal, and weight gain is fine. What does this baby have? So, amazing. It just has GOR, no D. We're just doing supportive management and reassurance. Perfect. So, celiac disease. So this is an R2. The R rankings for gastro are all over the place because I feel like celiac, again, is guaranteed to come up on your exam. You don't have to know that much, but it is guaranteed. So we all know it's an autoimmune disease that's characterized by intestinal hypersensitivity to gluten. And the kind of things that you'll be asked on your exam is it's usually a diagnostic question. So we're thinking about celiac as a differential if the child has altered bowel habits, poor weight gain or slow growth, especially buzzword here, buttock wasting is huge buzzword. If they have any anemia or iron deficiency that's treatment resistant often, any bloating or a family history of celiac disease or autoimmune conditions, this is when we're highly suspect. And the management is firstly education, but obviously the big thing is don't eat gluten, which is a really easy management to follow. Again, if you still have OSCEs, I think like if you were scoring extra points, it would be educating around the risks of malabsorption. So children who are diagnosed with illnesses young, they may sort of, I guess, tire of looking after themselves after a while is pretty common. So just educating around the risks of malabsorption and nutrient deficiencies into adulthood would be important. So things like osteoporosis. But that's going a bit beyond what we have today. So I'm not asking you these questions, but from the couple of exams that I went through, I had all of these celiac disease questions. So it came up almost every single time. And I'll highlight here, it is super buzzwordy. So it is a young child. So celiac disease has a peak incidence, 1 in early childhood and 1 around your 30s and 40s. So it's usually a 2-year-old, 3-year-old, 2-year-old. They have muscle wasting. They have buttock wasting, muscle wasting, slow growth, and then sometimes I'll throw in this like brother has diabetes, or occasionally they'll have diabetes, and essentially just to clue you into the fact that autoimmune diseases are a factor in this family. Okay, so infantile colic. So this is defined as crying more than 3 hours a day, more than 3 days a week for more than 3 weeks in a healthy baby under 3 months. Essentially, it's not acute, it's a chronic thing. And the biggest thing is like the baby's usually fine, but the parents are usually really distressed. The important thing to rule out here is parents can present with babies with this condition because of postnatal depression. So it's important to screen parents for that. And it's also babies' excessive crying is a strong risk factor for abusive head trauma. So that would be something that you would be thinking about in the back of your mind. But for an exam, it's just this non-acute crying. If it's acute, we're worried about these things over here, but I won't go into them now. Again, the management is just support, education, and reassurance. So we have this sort of crying curve over here, just to educate the parents that it will end. It's really tough, and making sure that they're okay. I've highlighted purple this carry baby in a papoose, not because it's important, but because I think it's really cute and funny. But this is all just sleep routines, support for the parents, and making sure they take a break so that they don't get overwhelmed and we don't put this child at risk of something like shaken baby syndrome. Encoparesis, this I have never found on an exam, but it's essentially fecal incontinence. So repeated involuntary or intentional elimination of feces and it's more than once per month for more than 3 months, but it's over the age of 4, so it's developmentally inappropriate. Where this might come up in your exams is that almost, so 80% of the time it's due to overflow diarrhea from constipation. So the management is treating that constipation. When it's not constipation, it's incredibly complicated and usually involving psychosocial stresses, mental health, and it's just very complicated and likely won't be asked in your exams. But the management is constipation management for children. So it's all behavior around toileting, positive reinforcement, reducing cow's milk because it decreases dietary fiber, but you're just making sure that kids are getting adequate fluid and fiber. You're not increasing the amounts. And then of course you can use laxative medications if required. Yes. Intestinal parasites. I think I've never seen amoebiasis on the exams, but we always do it in revision lectures. But the things that you will get, giardia. So it'll be a child, they'll be like returned from Bali or something, and the management is metronidazole. And it'll usually be 1 to 3 weeks after returning from their holiday. The other thing that does come up is you have a child who is waking up at the night with anal pruritus, and these kids have threadworm. The management is mebendazole, parental. I think this is usually the one that they'll give you on the exam. And the other important factors here is that you have to treat the whole family, you have to encourage good hygiene, and you wash all clothes and sheets in hot water. And the medication comes in little chocolate squares that children should hopefully like. How are we going for time? Okay, we're running close to time. Oh yeah, oops. So yeah, the management is metronidazole. So this is a pretty classic Monash question. Okay, cow's milk protein allergy. So there's not much to this, but it is important and it may come up. Essentially, this is a child who presents with feeding problems all the time. They have frequent vomiting, but they may also have diarrhea with blood or mucus. They'll have poor weight gain, and then the really like Monash thing is that they'll have all of these bowel symptoms, plus they'll have a widespread eczema. Another really easy condition to treat, you eliminate cow's milk for 2 weeks from the child's diet, and if they're still breastfeeding, then you modify the mother's diet. IBD, inflammatory bowel diseases. So this is our Crohn's and ulcerative colitis. In all my searching, I couldn't find a single question in the PEDS exams that talked about ulcerative colitis, but they did talk about Crohn's almost every single time. So the question will almost definitely be nothing around management, but it'll be, you have an adolescent, so not a toddler like with celiac. You'll have an adolescent who has diarrhea, abdominal pain, weight loss, but they have a lumpy shin rash. And of course, it has a chronic history. Should they ask you about ulcerative colitis, they might try and differentiate it with things like tenesmus and bloody diarrhea. But again, I've never seen it come up. And just to highlight again, it's really like Monash buzzwordy. So you'll have an 11-year-old or 12 that has a history of these gastro symptoms, and then they have either they'll call it by its name, erythema nodosum, or they'll talk about a painful lumpy rash on their shins. Okay, that's everything. So thank you very much for having me today. I hope that's helpful. If you have any questions, send me an email, but good luck for your exams. You'll all do great. It'll all be fine. But thank you.
Hi, Molly. Thank you for that. I just got a question sent to me asking how you differentiate between gore and gourd with a D.
Yep.
So if you just, yep.
I can go back to that. So anything in specifically or just generally?
I think they just mean generally.
Generally, yeah. So the biggest thing when you're looking through the exam question, so here we go, is if you're reading through the question and you don't see anything that makes you think, oh, this kid might be sick, it's gore. So it's just effortless vomiting. But the thing to note is the parents can be quite anxious about it, even if it's not actually causing the baby any harm. or distress, because some kids, it can happen a lot, and it can be really distressing. But when it's not just gore, you'll have any of these symptoms. So refusing to feed, which babies don't tend to do, that's like one of the only things they can do. You'll get really irritable babies while they're feeding because it's going to trigger that reflux. They might aspirate, which I think is probably harder to pick up on a history or exam. But if you just remember one thing for Monash exams, often they will say it's a baby with this increased amount of vomiting. They probably won't say effortless. And they also seem to have a chronic cough and or wheeze. If you remember just one thing to differentiate them, I would remember that. But otherwise, it's these feeding problems and slowed weight gain, or bloody vomiting, in which you'd be thinking it's more likely GORD or gore. Hope that was helpful.
Yep, they said yep. Perfect. Thank you for that. Cool. All right. Thanks for that, Molly. Mahesh is now going to take us through some peds surge, so I'll hand over to Mahesh.
Can you all see the slides? Awesome. Well, hey everyone. I'm Mahesh. I'm currently completing a BMed Sci this year in peds surge at Monash Children's. And as Nimik mentioned, I will be taking us through the peds surge conditions this morning. In terms of what we'll be covering, I'm just going to start off with a couple of tips or clinical clues that I found particularly useful in delineating potential differentials. And then I'll be just running through the matrix conditions, dividing them into the gen surge conditions and then the urology conditions. So starting off with our first clinical clue, particularly for the general surgery conditions, I found that this is by far the most useful way to pick apart differentials for the exams, and that is looking at the age in which a patient presents. So typically, earlier in the timeline, we're looking at conditions that have developed during embryological development, and are therefore sort of congenital. And these conditions also typically more severe. So sort of in the first 2 weeks of life, we'll go through all these conditions in a moment, but we'll be looking at your atresias, your malrotation and volvulus, your Hirschsprung's disease, as well as your necrotizing enterocolitis. And then sort of anywhere from 2 weeks all the way to adolescence. These conditions are typically ones that develop over time. Although a lot of them are due to congenital defects, they typically present subacutely and are a bit less severe. So between the 2 week and 2 month mark, pyloric stenosis typically presents during that time. From 2 months to 2 years, intussusception, and then sort of 2 years onwards all the way to late childhood. This is where you can get appendicitis, testicular torsion, as well as a late presentation for Hirschsprung's disease for sort of more mild disease. And then a second sort of clinical clue that's particularly useful for delineating differentials is looking at sort of the picture in which the patient presents. Are they sort of presenting more with a proximal or a distal pathology? And they all have their own sort of associated signs and symptoms. So when we're talking about proximal pathology, this is all conditions from the mouth to the small intestine, and I've sort of listed the conditions that would refer to. And these patients typically present with vomiting, where when you compare that to a distal pathology, going from the cecum to the anus, they would more likely present with more significant abdominal distension. They may have vomiting, but usually abdominal distension is a symptom or sign that you'll pick up first, always sort of mentioned in the MCQ. And then with investigations, with our proximal pathologies, we usually go for an abdominal X-ray, an upper GI contrast study, And a lot of the conditions you would need to look at a full blood panel because they may be having some metabolic derangement from the vomiting. And then with distal pathologies, usually an abdominal x-ray is sort of sufficient to make a diagnosis. So just looking at the differences that you could see with the abdominal x-rays between your proximal and distal pathologies. So with your proximal pathology, I guess with these x-rays, I like to just make sort of a division around the umbilicus, which is sort of L4, L5. And then with proximal pathologies, you typically see more gas in the abdomen above the umbilicus. And also you would see sort of fewer bowel loops. So in this image, you can see a clearly distended stomach. And then with distal pathologies, you typically see more gas in the abdomen, sort of below that umbilical marker. And here you can see lots and lots of bowel loops. Not quite a clinical clue, but this sort of applies to any pediatric surgical condition. So if you're thinking a child is going to be urgently referred to ped surg, or is going to have surgery soon, or has an acute abdomen, without fail, you can always mention these things as part of your initial management plan. I like to divide it into groups of twos, and you can sort of do it in this order as well. So there are two talking things, which you refer the patient to ped surg and explain to the parents what's going on. There are two oral things, so keep the patient nil by mouth and insert a nasogastric tube. Two IV things, you'd cannulate them, get baseline bloods, and rehydrate them. And then two medical things, which is giving them analgesia and antiemetics. So this is sort of easy marks in your OSCEs that you can always rattle off when you think there's some sort of pediatric surgical condition happening. So onto the matrix conditions. As in terms of the detail, I try to sort of distill it down to what you probably need to know for the exams. So the first one, and I've sort of gone through them from I guess the initial timeline, in terms of the timeline, starting with the first few days of presenting, all the way to perhaps later down in adolescence. So starting off with atresias. Atresia literally means just congenital blocked lumen. And in terms of the types of atresias you get, they're defined by the location. So starting off with esophageal, duodenal, jejunal, then ileal. And your esophageal atresias may also be associated with what's called a transesophageal fistula. So if we just sort of look at the image on the bottom right of the screen, A is sort of your classical esophageal atresia. And as you can see, there's a cease in development of the esophagus leading to the blocked lumen. And then sort of your B, C, D, and E is your esophageal atresias, and that's also associated with a connection to the trachea. And this is what's called your transesophageal fistula. And interestingly, a TOF is actually more common than a classical esophageal atresia. And then so the image on the left shows what you might see with a duodenal atresia, and it's similar for a jejunal or ileal atresia as well. In terms of how atresias present, they present within the first few days of life because it's sort of an anatomical deformity. They're often characterized as a well bilious vomiter. So they're well and they vomit bile. Apart from esophageal atresia, all the others are sort of below the ampulla of Vata, so leading to sort of bile vomits. They may also get abdominal distension, and these conditions are often associated with Down syndrome as well. In terms of investigations, so this is a proximal pathology, so we're thinking about those proximal pathology investigations. So you do the full blood panel, an abdominal X-ray, and you may consider doing an upper GI contrast study, though the abdominal X-ray is usually enough to make a diagnosis. And in terms of some of the buzzwords they like to throw in with with the X-rays, so with the duodenal atresia, you get what's called the double bubble sign. So if we see on the left-hand X-ray, there's two bubbles. The first bubble is related to the stomach, and then the second one is in the duodenum, sort of after the atresia. And you can also get something called a triple bubble sign, which is sort of shown on the right-hand image. But they usually go for duodenal atresias in your exams. And in how we manage atresias, we do that baseline surgical workup. So remembering the 2 talking things, the 2 oral, the 2 IV, and your 2 medical things. And then you would then go and surgically correct the abnormality. And specifically for a duodenal atresia, the surgery name is a duodenojejunectomy. They essentially just remove that, or they just anastomose the 2 parts of the healthy bowel and remove whatever is the problematic part that's leading to the atresia or the congenitally blocked lumen. And you'd also consider karyotyping as well, sort of in the follow-up period, particularly if you're concerned about Down syndrome, for example. So malrotation and volvulus. So malrotation refers to the sort of the incomplete rotation of bowel during embryological development. And what this leads to is essentially abnormal mesenteric attachments to the posterior abdominal wall, and a narrow mesentery base. And it also includes what's referred to as LAD bands, which are just formations of mesentery that are abnormal in the abdomen. And it sort of refers to the procedure that we'll mention in a second. And the volvulus is then where the bowel twists on itself in a significant manner that leads to a bowel obstruction and an ischemia. And then that's because of those abnormal attachments. In terms of how they present, they initially are sort of vaguely irritable with sort of when the bowel is sort of twisting, but it hasn't led to an obstruction. And then once the volvulus occurs, this is when they get severe pain, bilious vomiting, and significant abdominal distension. You would investigate them with an abdominal X-ray where you get that proximal obstruction pathology picture. And on an upper GI contrast study, this is where we would see what's called the corkscrew appearance. So this is the image of the upper GI contrast study, and this is sort of where that corkscrew appearance comes up. And in terms of them, how they're managed, you have your baseline workup and then the LAD procedure, where they sort of untwist the bowel and then they correct the malrotation. And this is often done over multiple surgeries, where they dissect those LAD bands or those abnormal attachments and then fix the mesentery. And post-op, these patients would require antibiotics as well and parenteral nutrition. Hirschsprung's disease, which is essentially what's called distal colon aganglionosis, which is where during development the mesenteric plexus sort of develops from proximal to distal, and the distal part of bowel does not have the mesenteric plexus in Hirschsprung's disease. And what this leads to is permanent contraction of bowel, and of the component that's affected. And then proximal to that, there's dilation of bowel, and that's often referred to a megacolon. And the risk factors for this condition are males, Down syndrome, very preterm infants, and neurofibromatosis. They present in the first few days of life, and they typically present as failure to pass meconium or their first stools. And in sort of less severe cases where they present later, sort of after 2 months, they might just have constipation in the earlier part of their life. And they, on examination, have distension. They may get growth delay, and the buzzwordy sort of sign is on a PR exam, you get what's called a squirt sign. It's not pleasant, but essentially on a PR exam, you sort of relieve the obstruction of the distal part of bowel, and you just get a release of bowel contents, and that's what the squirt sign is. And on investigations, you can do an abdominal X-ray where you get a distal picture, though the gold standard is a rectal suction biopsy, and sort of under pathology, you can actually see that there's an absence of those nerves. And in terms of management, the definitive management is a pull-through procedure, which is essentially they just pull through, remove the bit of bowel that's affected, and then connect or anastomose the healthy bowel up to the anus. And this is just an image just highlighting where proximally you have a dilated segment that's normal, and then distally there is no ganglion cells, and it's quite narrow and contracted. Necrotizing enterocolitis. This condition is quite poorly understood in terms of how it comes about and its pathophysiology, but it's comprised of two parts. So necrotizing referring to that dying piece of bowel, and the colitis suggesting that there's an infective component. And unfortunately, these kids are quite unwell and have a high mortality rate. The major risk factors for them are premature infants and kids that are formula fed. They present with abdominal distension, typically a distal obstruction, and a septic sort of picture with vomiting, with things like fever, vomiting, and blood and stools. You would investigate them with a full blood panel, and things you might see are sort of elevated inflammatory markers and a metabolic acidosis, because of the necrotizing bowel that leads to increased sort of lactate in the blood, which leads to the acidosis. And on abdominal X-ray, the buzzword that's used is pneumatosis intestinalis. I admit I'm not a radiologist, but it essentially refers to gas in the wall of the bowel, which you can kind of see where the two arrows are pointed, but a bit of a tricky one to pick up on X-ray. And in terms of the management, you would decompress them with an NGT. You would start them with broad spectrum antibiotics with benpent and gent. And the management would be sort of resecting the dying pieces of bowel. And often these babies are at higher risk of what's referred to as chop-out syndrome, where because you've resected too much bowel, it's essentially a bit non-functional, and they'll require sort of lifelong parenteral nutrition. Pyloric stenosis is where you get gastric outlet obstruction due to hypertrophy of the pyloric sphincter, where the pylorus is sort of the most distal part of the stomach. And this leads to sort of obstruction and dilation proximal to that sphincter. In terms of how they present about just after 2 weeks to up to 2 months of life. And the big buzzword here is projectile vomiting. And literally their vomits would sort of exceed where their feet are, or they might be getting vomits straight onto the walls and things like that. And their vomits are typically milky, usually right after a feed, that's when they would vomit. They also refer to happy, hungry vomiters. So they're quite well, and they'll sort of vomit and then be hungry, and they're happy to feed again, and then vomit, and then they vomit straight after. It's a bit of a cycle. And then on examination, you get distension. You can get something called the olive sign, which is just an abdominal palpation. You can actually feel the enlarged pylorus. You may see visible peristalsis, and there's something called a succession splash, where essentially you feed the baby, and then after sort of a couple of hours, if you sort of move them about, you might actually be able to hear the sloshing of the fluids. Obviously, don't go around shaking babies, but it's an interesting sign. And then on investigations, you can get because they're losing a lot of stomach acid, you can get a hypochloremic, hyperkalemic metabolic alkalosis. And on abdominal X-ray, you'll see a sort of a really dilated stomach, though the best test that's used is an abdominal ultrasound to diagnose it. And the management is you initially want to hydrate them and correct the alkalosis and then send them off to surgery. And the surgery that they do is a Ramsted's pyelomyotomy, which is they essentially just make a cut or an incision in the hypertrophic muscle, sort of to relieve the obstruction. And when it heals up, it usually heals up back to normal. Intussusception is where we get invagination of like a proximal piece of bowel into a distal segment like that. That's also referred to as telescoping, and this leads to intestinal obstruction. There are a few sort of examples, or I guess there's an image here of how that sort of looks like, the telescoping. In terms of its etiology, 90% of it is idiopathic and at that ileocecal junction. And apparently it may be associated with Peyer's patches, which is sort of that immune tissue. And in 10% of cases, there's some sort of secondary cause, which is often referred to as a lead point. This could be Meckel's diverticulum or like a tumor or a hematoma. They present 2 months to 2 years. They're in quite a lot of distress. And they can also be associated with colicky abdominal pain, sort of where you get that telescoping and then the telescoping relieves, and then you get the telescoping again. So each time you get, when there is evagination, that's when they get that abdominal pain. In terms of their bowel symptoms with how they progress, they start off with early bloody diarrhea, which then can turn into red currant jelly stool, which then can lead to, then later on they get constipation. And red currant jelly stool is sort of a buzzword that you like to use in the exams. And on examination, you would get distension, and you might be able to feel what's referred to as like a sausage-shaped mass on palpation. On investigations, on an abdominal X-ray, you'll get that proximal obstructive picture with a crescent sign. But what's probably a bit more easier to identify is on abdominal ultrasound, you get what's called a target sign. And it sort of looks like a target because you can sort of see the two bits of bowel, sort of one in the other, the proximal bit in the distal part of bowel. And the gold standard diagnostic test, and it's also therapeutic, is a gas enema. And so a gas enema reduction is the management for this condition, where you essentially try to push back the intussusception by introducing gas through the sort of the rectum. It's 75% successful in its first attempt, and they usually attempt it twice. However, some of them do recur, and if there's a fail reduction or there's other complications like bowel infarction or perforation, they're then taken to surgery. Appendicitis, I'm sure you guys are sort of all over from last year. But just a couple of points. So simple, it's often useful to differentiate between simple and complex appendicitis, particularly for management. So simple is sort of acute inflammation just confined to the appendix, where a complex case would be where there's a perforation of the appendix or some pus or some sort of other mass, like an abscess. Presentation, I'm sure you guys are all over. And in terms of the management, you do a lap appendicectomy. The antibiotics are GAM. And this is where knowing the simple versus complicated helps. So for simple cases, you cease antibiotics straight after surgery, where in complicated cases, you'll want to continue antibiotics for at least 5 days post-op. So these are a couple of abdominal wall defects. Don't really need to know too much about them apart from just identifying them. So the first one is exomphalus, where this refers to sort of a defect in the umbilical muscle or wall. And then as a result, abdominal contents herniates into the umbilical cord. And because it herniates into the umbilical cord, the abdominal contents are covered by a membrane. And these defects are typically midline and can be associated with congenital syndromes. The other one is gastroschisis, where there's a defect in the abdominal wall rather than the umbilical wall. And then abdominal contents herniate through. And here there's no membrane or sort of protective layer covering the abdominal contents. And it almost always occurs to the right of the umbilicus. So midline, right of the umbilicus, membrane, no membrane. That's usually how you differentiate them in the exams. CDH is essentially, there's a defect in the diaphragm, and that leads to abdominal contents entering the thoracic cavity, usually diagnosed on antenatal scans. Presents in the first few days of life. They're very sick, and on an abdominal x-ray, you can quite clearly see that bowel is where it should not be, up in the chest. Okay, finally, there's only a few sort of peds urology conditions. So first one is hypospadias. You just sort of really need to identify the 3 key clinical features. So one is the hooded foreskin. Hang on, let's go back. And then second is the ectopic urethral meatus. So it's not at the tip where it should be, but it might be somewhere more proximal. And then ventral chordae, which is essentially sort of an excessive curvature of the penis. And it's usually actually more significant than what's depicted in the picture. It can sometimes be like almost like a right angle. There are 2 types. You don't really need to know too much about this, but the more proximal the defects are, the more significant it is, and the more surgery that's required to correct them. You usually correct them around 9 to 12 months. And then you just sort of correcting the 3 sort of features that we just mentioned. And yeah, the worse the severity, the more surgeries you might require. Undescended testis is failure of normal normal testicular descent into the normal scrotal position. About 3 to 4 infants have this at birth, and it's worth noting that most of them will descend by 3 months. So as a result, you wouldn't correct them prior to that time. There are a few definitions to help classify them. So retractile is when you manipulate the scrotum down on examination, it stays there. Ascending is where you can no longer sort of keep the testicle in the scrotum without tension. Ectopic is where it's sort of not in the normal line of descent. And impalpable is like you can't palpate the scrotum, so you might need to do laparoscopy to sort of determine where it is. Management is an orchidopexy, and once again, you do them typically after 3 months. And complications, so why do we care about correcting an undescended testes? It can lead to infertility and increased testicular cancer risk, and also an increased risk of testicular torsion as well. The final thing that I have is the inguinal scrotal swellings. I have sort of 2 summary tables over the next 2 slides, and which feel free to go into more detail in your own time. It is an R2. So the main thing I would say that you need to know is, as opposed to knowing each condition in detail, but you would probably just need to know how to differentiate between them. So the first thing I look at is it painful? So there are 3 conditions that are painful, and then on the next slide there are sort of non-painful conditions. And then you look for, and then there are sort of certain buzzwords that I look for. Hey, Namik, I'm aware I'm just around 10 o'clock.
No, I think I'm happy for you to take a few more minutes. I feel like this is
Yeah.
all super high yield, so please feel free to keep going.
Yeah, no worries. So this is the last condition anyway. So if the person has a swelling in the inguinal scrotal area and they're in acute pain, so these are the 3 conditions you would look for. So first, starting off with sort of testicular torsion, that's when they sort of twist on the testicle, twist on the spermatic cord, and that leads to ischemia. Sort of key buzzwords to look out for: it's sudden onset pain. They get a high riding testis that's asymmetrical. They'll get a negative cremasteric reflex, which is essentially where if you stroke the inner thigh, a positive sign would be that the testicle will sort of go up or rise. So a negative reflex means that it doesn't happen. And then a negative Pren sign is where when you lift the testis, it doesn't relieve pain. You investigate with a Doppler ultrasound to assess blood flow in case of ischemia. And the most important thing is it's a surgical emergency where you can get irreversible damage after 6 hours if it's not sort of corrected. Torsion of the testicular appendix is sort of the main differential when it presents. The main differential you have to be aware of that's kind of similar to a testicular torsion. However, it's more of a gradual onset over 1 to 2 days. That's less severe. And you can get what's called the blue dot sign, which you can actually see sort of a blue pea-sized swelling at sort of the upper pole of the testis. And this one is not as urgent and usually resolves within 2 to 10 days without sort of any surgery. Epididymoorchitis, can't pronounce that at the moment, is sort of inflammation or infection of the epididymis and testis. You get sudden pain. Because it's an infection, you get systemic illness type symptoms such as fever. In this case, you get a positive cremasteric reflex and a Pren sign. Because it may be due to an infection, you do some investigations for that, such as a urine MCS, and you'd manage that with antibiotics, pain relief, and it's slow to resolve, but we sort of manage for symptomatically for a few weeks until it does. And then we have your inguinal scrotal swellings that are non-painful. So starting off with like sort of an inguinal hernia, which is where you get protrusion of abdominal contents through sort of a passageway between the abdomen and the scrotum called the inguinal canal. And here, the typical sort of the descriptive feature is you can't get above the swelling. And these swellings can be reducible back into the abdomen unless they're sort of obstructed. And the management for that is a surgical repair with different timelines depending on the age of the child. A hydrocele is similar, where there's sort of a congenital defect called a patent processus vaginalis that allows sort of a connection between the abdomen and the scrotum. However, it's just you just get a collection of peritoneal fluid in the scrotum as opposed to abdominal contents. So the defect's usually a bit smaller. These it's a not irreducible swelling as opposed to an inguinal hernia, and you get what's called a positive transillumination sign, where you sort of shine a light behind the scrotum, and it sort of glows a bit, and these sort of resolve spontaneously most of the time. Varicocele is sort of enlargement of the veins of the panpimiform plexus in the scrotum. You get that typical bag of worms appearance. And these are typically sort of left untreated, though some patients would like to go surgery for sort of cosmetic reasons. And then finally, there's idiopathic scrotal edema, which usually occurs in the setting of nephrotic syndrome. You get a rapid onset of swelling that's bilateral, where a lot of these other conditions are sort of a unilateral presentation. And you get this purplish discoloration, and this also usually resolves about in 1 to 5 days. The other inguinal scrotal swelling that's non-painful that I don't have on these slides is that undescended testis, which we sort of went through just before. Cool, that's all I have. Thanks for listening, and I hope you guys have the bestest of exam seasons, and good luck. I'm sure you guys will do completely fine.
Thank you for that, Mahesh. Any questions for Mahesh you guys want to send through now?
I did have one question on my DMs. So,
Yep.
so the question is gastroschisis associated with any congenital conditions? To my understanding, it's not as prevalent as the exomphalus. However, I'm not actually sure about the specific details. I'm happy to get back to you on that. They may be associated. I'm sure there are probably cases where they are, but it's just not as obvious as exomphalus, and it doesn't usually come up in exam questions as well as being associated with anything else. No worries. So just another question about what does it mean by you can't get above the swelling in inguinal hernias? So when you're sort of palpating the swelling in the scrotum, when you're sort of moving proximal to work out, or when you're palpating around it, you know, sometimes when you're palpating for a mass, you can sort of feel all the edges and you can actually feel the entire mass. With the inguinal hernia, you're sort of palpating around and you move more proximal and you can't actually reach a point where you can feel the entire mass or the entire swelling. It sort of continues into the abdomen because it's sort of a hernia. So it comes from the abdomen into the scrotum. So you can't actually feel the end point per se of the swelling. That's sort of what it refers to. Were there any other questions that you received, Namik?
No, I haven't gotten any. I think you've answered all of them. So thank you for doing that again. We really appreciate that. Thank
No
you.
worries. I'm happy to stick around for a bit. So if you guys still have any more questions, you can DM me and I'll happy to answer them too.
Thank you.
Cool.
All right. Our next topic is going to be on hematology and oncology. And Nikita is going to take us through that.
Yeah, hi guys. I'll just share my slides. So you guys, I'll put it in presenter mode. Okay, can you guys see those? Okay, so we'll start off then. So I'm doing pediatric heme and onc today. So in terms of what we're covering, there's 3 R1 conditions, a few R2s and a few R3s. So hopefully we cover at least the R1s and R2s. So starting off with iron deficiency anemia, essentially it's a serum ferritin that's less than 20, just be careful of the units, associated with a low hemoglobin as well. Sorry, the slide's not changing here. Okay, so it's the most common anemia in children and the etiology of anemia. There's 3 different etiologies you can have. So we can look at infants, usually insufficient iron food consumption or excessive cow milk consumption. In children, it's mainly associated with their diet or malabsorptive disorders. And then in adolescents, as above, plus or minus menorrhea from starting the menstrual cycle. So this is one framework. Another simple framework to look at this is just looking at poor intake, excessive loss, and malabsorptive disorders. In terms of history, quite vague symptoms. So impaired cognitive function, decreased memory, impaired learning and concentration, behavioral disturbances, fatigue, and pica. I guess my biggest advice would be last year we had an OSCE on this or in exam questions, they're more focused around risk factors or clues around the etiology for iron deficiency. So here are a few risk factors that you guys can look at in your own time. So in terms of the investigations, what we're going to see is we're going to see a microcytic hyperchromic anemia when we look under the microscope. So microcytic meaning that the red cells are smaller, hyperchromic meaning that they've got less color due to the lack of hemoglobin. Your MCV is going to be less than 80 and your hemoglobin is going to be less than approximately 120, but the range differs depending on the age group. Your serum ferritin is also going to be low. I guess one of the important facts to remember that ferritin is an acute phase reactant, meaning that if you're testing it when someone is in a state of infection or inflammation, it might falsely be normal or elevated when it's actually lower. So you should really be testing ferritin when someone is not sick. And then in terms of management, there's a few different things. First, we can start off with dietary advice. So just increasing iron-rich food consumption, reducing cow milk consumption, and considering a dietitian referral. Oral iron supplementation, which usually children will take for 3 months with vitamin C, informing parents of side effects such as constipation, black stool, and teeth staining. And if they are very severely anemic, doing follow-up in 1 week with a repeat hemoglobin. And if it's even severe, we can do IV iron infusion. And in terms of kids, majority of kids aren't able to take tablets. So just considering the fact that we're actually using oral iron formulation, so mixtures and in liquid form. So the next topic we're going to look at is ALL. So one of the things that I didn't understand was the difference between leukemias and lymphomas. And this is most of what I could find. So for leukemias, they're usually present in the bone marrow, and that's where they start. You've got immature blast cells, and then those proliferate, result in overcrowding of the bone marrow, which results in them spilling out into the peripheral circulation. So that's why your FBE can often be diagnostic, and you also do a bone marrow biopsy. Whereas for lymphomas, they're mainly present in the lymph nodes, lymphoid tissues, or lymphoid organs, and usually they don't spill into the peripheral blood, and rarely they present in the bone marrow, but they can, it's just rare. Which means that peripheral blood is often not diagnostic, and we often need a biopsy of the mass. So looking at just hematopoiesis, I thought would be a good way to start. We've got the splitting that happens here. The acute lymphomas are more aggressive and fast. The chronic ones are more indolent and slow growing. Essentially, chemotherapy usually targets cells which are rapidly proliferating. So I think acute lymphomas are easier to treat. You guys can fact check me on that if that's wrong. But just keeping this diagram in mind is important. So moving on to the epidemiology, ALL is the most common cancer in childhood, usually happens in 2 to 5 year olds. Usually if it's happening in an age group that's slightly older than that, the prognosis can be a little bit worse. B-cell lymphomas are much more common than T-cell lymphomas, typically associated with Down syndrome, and it's curable. So etiology, and essentially you've got the uncontrolled proliferation of the immature lymphoid cells, so quite high up in the hematopoiesis that we looked at before. You've got increased white cell count, but majority of those are immature white cells, which is why your neutrophils and your lymphocytes will be low because you've got low mature white cells. So most of the increased white cell count is due to the immature blast cells. And this often results from de novo mutations, such as in the Philadelphia chromosome, which I think is a translocation in the 9 and 22 chromosomes. In terms of risk factors, age, children less than 15, exposure to high levels of radiation chemicals, and certain genetic syndromes. So we said Downs before. Clinical presentation. So the first thing is you get pancytopenic syndrome. So you've got low RBCs, which result in anemia. So you've got pallor, fatigue, malaise, lethargy, so very generalized symptoms. Then you've got low white cells, so you've got neutropenic symptoms, frequent infections, being febrile a lot. And then you've got low platelets, so thrombocytopenia. So you guys can get petechiae, ecchymosis, and purpura. Petechiae, the small pinprick points, and these are increasing in size. You've got easy bruising and spontaneous bleeding. Systemic symptoms such as fever, loss of weight, and anorexia. And then we've got infiltrative or metastatic type symptoms. So if it mets to the bone, you can result in bone pain. And that's because the bone marrow is expanding to accommodate the lymphoblasts. It can go to the liver and spleen, which results in hepatosplenomegaly. If the liver and spleen are getting bigger, that's going to result in nausea and vomiting due to compression, and abdo fullness can result in lymphadenopathy, which is often painless and generalized. If it spreads to the CNS, it's quite serious. So that can result in meningism type symptoms. And then CNS6 palsy, which is, I think, the abducens nerve, so failure to abduct. If it goes to the testes, testicular enlargement, and often with T cell ALL, which is less common than B cell ALL, those originate in the thymus, so you can get thymus enlargement. So you can get dyspnea due to compression of the trachea, Horner's due to compression of the SVC, and dysphagia due to compression of the esophagus. Investigations. So often with bloods, you're going to see a high white cell count, but a low neutrophil or lymphocytic count. You might also have low hemoglobin and low platelets. In terms of your blood film, you'll often have leukocytosis with lymphoblasts, and I think that has to be more than 20% lymphoblasts. So yeah, that's where you do it. So you do a bone marrow aspirate, ALL will be more than 20% blasts. And then we can do a chest x-ray or a CT chest, looking for masses or thymic enlargement. We can look for hepatosplenomegaly on an ultrasound. We can also do a lumbar puncture, CTB, MRIB, and these are essentially looking for CNS disease. Often, I actually did my placement on Peds Onc this year. They also do intrathecal methotrexate. So first of all, everyone gets a lumbar puncture who has ALL at diagnosis. They'll get a cytology of the CNS fluid to see if there's leukemic cells in the CNS. And then they'll also give a dose of methotrexate intrathecally during the lumbar puncture so that if there are leukemic cells, you can target them. They also do a testicular ultrasound for testicular mass, and essentially all of these tests here are looking for leukemic infiltration. We can also do immunohistochemistry, which is looking inside the cell. So they're looking for different markers, and then flow cytometry, which is looking for proteins outside the cell, and genetic studies, which will guide therapy more specifically. In terms of management, there's a few different parts. So with low hemoglobin and low platelets, we can often transfuse patients with packed red blood cells and platelet transfusions as they need it. We also do chemotherapy, which is often a combination of different things, but I've just put examples of what I saw a lot on placement. So they used a lot of PRED, pegasparginase, vincristine. The intrathecal methotrexate is paired with folinic acid. And then the adverse effect of chemotherapy is febrile neutropenia, which is a medical emergency. And I have a slide on later. And of course, if treatment is refractory to all of this, patients might have to get an allogenic bone marrow transplant. Also, the chemotherapy usually follows kind of 3 stages. So induction, consolidation, and maintenance, which you guys can read up on if you're interested. So complications, I've just put this here for your own interest. The only thing I'll point out is chemotherapy. It targets cells, and once cells are targeted and killed, they will lyase, and they will release a bunch of potassium and uric acid, which can often result in AKA and gout. So often patients who are receiving chemotherapy may also be put on IV fluids, as well as allopurinol, just to bring the uric acid levels down. Febrile neutropenia, you guys don't need to know this, but it's still important to know. So essentially, if NEUTs are less than 1 and a patient is febrile, it's a medical emergency. You want to call a met call. Essentially, there should be 2 blood cultures within 30 minutes prior to antibiotic administration, but it should not delay antibiotic administration. Usually the antibiotic they use is peptides because it's quite broad spectrum. And then they can send off all of these tests to look for a source of infection. So please get senior help. Usually a reg or a fellow has to review the patient urgently if someone presents with febrile neut. The next condition is ITP. So ITP is often, it's the destruction of platelets by IgG antibiotics. Sorry, I think I meant antibodies. That's my fault. So you've got spleen autoantibodies against these things here. And it results in an isolated low platelet count of less than 100 in a well child with an otherwise normal FBE and film. So hemoglobin should be normal and the white cell count should be normal. History will often be thrombocytopenic symptoms such as bleeding, so epistaxis, gum bleeding, gastrobleeding, hematuria, menorrhea, and rarely intracranial hemorrhage, which would be an emergency, petechial rash or bruising. It's often associated with a preceding viral infection or recent live virus immunization, and they're often well-looking, and there's no real malignant signs. Of course, you should really make sure you're excluding your red flags, especially ALL and non-accidental injury in these cases. So if you had any of the following symptoms, you would definitely want to investigate further before diagnosing a child with ITP. Investigation, so FBE, isolated thrombocytopenia. You might have a little bit of leukocytosis from a recent infection. You might consider doing coags to rule out vitamin K deficiency or HIT, so other reasons for bleeding. Blood film to exclude leukemia if relevant and the patient presents with other non-specific symptoms. Bone marrow biopsy, not that they routinely do this, but if they did, it would show a lot of megakaryocytes because you've got low platelets, so your precursor, your immature platelet cells, or where they originate from, are going to be high. And you can consider doing urinalysis to rule out Henlock-Schönlein purpura, which we'll talk about soon. So management, one of the things that's really important to do is risk stratify. So you will not manage a patient based off of their platelet count. You will manage a patient based off of their symptoms in ITP. So if someone is well clinically and their platelet count is above 20, you don't need to give them any sort of therapy or medication. These patients are counseled to avoid NSAIDs or aspirins because that would increase their bleeding risk even more, as well as avoiding contact sport. If it's deemed that they need oral corticosteroids, they'll get prednisolone 2 to 4 milligrams per kilogram to induce remission. Sometimes IVIG if mucosal bleeding is present. In really severe cases, patients may get a splenectomy. It's curative, but of course, they're going to require vaccination as well as lifelong prophylactic amoxicillin for life. And this works because it's eliminating the antibodies and the site of destruction of the platelets. And if the patient has life-threatening bleeding, you might give them a platelet transfusion. So this is just a diagram that you guys can look at about the previous topic. And now we're going to move on to lymphomas. So lymphomas are solid tumors arising from normal lymphoid tissue. And the normal lymphoid tissue may be lymph nodes, liver, spleen, Walde's ring, the gastrointestinal tract, and essentially this is a cancer of the mature lymphocytes, which is different from ALL. So just a bit of revision, we've got hematopoiesis. You've got your precursor B cells, which goes to your lymph nodes and can become plasma cells or memory B cells. You've also got the T cells, which go to the thymus, and they can differentiate into CD4 plus T cells and CD8 plus T cells. I've popped this in and I have a bit of an explanation in the notes where you can read the pathophysiology if you're interested, but there's no need to explain that. So in terms of the epi of Hodgkin's lymphoma, 10% of lymphomas, so non-Hodgkin's is 90%. There's 2 peaks of incidence, so 15 to 40 and 55 plus, and it typically has better prognosis than NHL. Essentially, you've got the malignant proliferation of a type of B lymphocyte, typically your Reed-Sternberg cell, and the risk factors, essentially it's associated with virus exposure, so EBV or HIV. Essentially, it's because these viruses may result in high levels of this factor, which decrease apoptosis, causing these cells to accumulate in the lymph nodes. So we've got various different types. We've got classical Hodgkin's lymphoma, which makes up 95%. These typically you guys don't need to know it to this much detail. I've just put it in for interest's sake, but they don't express CD45 or 20. They do express CD15, 30, and that's how they differ from nodular lymphocyte predominant HL, which has the opposite CD expression to classic HL. There's 3 types of classical Hodgkin's lymphoma, so nodular sclerosing, lymphocyte predominant, and lymphocyte deplete. And then these ones are slow growing indolent, but they have a high cure rate, and they're associated with the popcorn cell. So with Hodgkin's lymphoma, usually the presentation is this painless lymph node enlargement, often localized to a single axial group with contiguous spread. So it spreads close, it doesn't really go to far away places in the body. So you can get lymphadenopathy that's either cervical, supraclavicular, or axillary. Usually the lymph nodes are rubbery when you feel them. You can get shortness of breath due to the compression of trachea, chest pain due to the compression of the pericardium, and SVC syndrome due to the compression of the SVC. Weirdly enough, Hodgkin's is associated with a pruritus. It's due to hyperactive basophils being released due to which induce histamine release. B symptoms are very, very common with Hodgkin's lymphoma. So loss of weight, night sweats, fatigue, and often alcohol-induced lymph node pain is like the buzzword in exams. So when we do our investigations, we can do an FBE, a blood film, which will show your classic Reed-Sternberg or owl eye appearance. I think in exams, they're kind of moving away from buzzwords. So they might write multi-nucleated or something different from the typical owl eye or Reed-Sternberg appearance. They can do a bone marrow aspirate, but typically you need to do a lymph node biopsy, CT scan looking for mets, and flow cytometry and histopath. Typically management is chemotherapy or radiation. I think I just repeated the slides. So then we've got the Ann and Arbor staging for Hodgkin's lymphoma, which you can have a look at, but it splits it up midline and looks at spread that way. So non-Hodgkin's lymphoma makes up the majority of the lymphomas. They're going to arise from B, T, and NK lymphocytes, but majority, again, are B-cell in origin. We've got different types. So we've got the indolent ones, which are more the follicular marginal mantle cell, potentially more difficult to cure with chemo, and aggressive, so diffuse lymphocyte B-cell lymphoma and Burkitt's. So indolent lymphomas can become aggressive if they acquire more mutations, and that's called Richter's transformation. In terms of the clinical presentation for this, it's again painless lymph node enlargement, but whereas Hodgkin's is more contiguous spread, this will go to peripheral sites. So it's said to be extranodal. It'll go to the GI tract, result in bowel obstruction, potentially bone marrow can result in pancytopenic symptoms, spinal cord can result in loss of sensational weakness in the lower limbs or upper limbs, depending on the level. You can also get a hepatosplenomegaly. B symptoms tend to be a little bit more uncommon, so loss of weight, night sweats, fatigue, but you can still get them. Again, investigations are similar. The only difference is you'll have a starry sky histology, which I haven't included a picture of, but you guys can go Google that, and management's the same with chemo or radiation. And this is just a table for your own learning, which you can look at on review. So the next thing we're looking at is hemophilia. This is just for your own recap, but I guess what's relevant for hemophilia is factor 11, 9, and 8. So those are all in the APTT pathway or the intrinsic pathway. So hemophilia is a deficiency in clotting factors. 70% of these are X-linked recessive. In terms of epidemiology, 1 to 4,000 to 1 to 5,000 live male births. So you've got A, B, and C. A is a factor 8 deficiency. B is a factor 9 deficiency, and C is a factor 11 deficiency. I think I meant APTT, so prolonged APTT with normal platelets and prothrombin time. Again, all of these are going to have those same findings. So prolonged APTT, normal platelets, and normal prothrombin time. Presentation is any sort of bleeding or spontaneous bleeding, whether that be into the joints or epistaxis, and so forth. Investigations, you can do an FBC or FBE. If they've got recent bleeding, they might have a reduced HB. Your PT, fibrinogen, 1 Willebrand's factor are all going to be normal. Your APTT will be prolonged because these are all acting on the intrinsic pathway. But when you mix it with donor plasma, which does contain the factor that you're missing, the APTT should normalize. And then in terms of management, it's really prophylactic factor 8. And then if they're getting acute bleeding episodes, they're going to go to hospital and they might be given fresh frozen plasma, but you'd really be contacting heme at that point for advice. So HSP, Henlock, Schonlen, Pepper, it's an IgA vasculitis. Most of what you need to know is the buzzwords. A 5-year-old boy with a recent ERT presenting with abdominal pain with a peperic rash on high pressure areas. So that's like the buttocks. Essentially, it's the most common vasculitis of pediatrics, most common in 3 to 10-year-olds with a male predominance preceded by an ERT. Essentially recent infection with any of these potentially, as well as vaccination. You've got IgA immune complexes, which are going to deposit in the small blood vessels of skins, joints, and kidneys, or the gastrointestinal tract, and that will all result in an inflammatory reaction, which kind of fits into the presentation. So you can get a palpable peperic rash on the buttocks, extensor surfaces of arms, legs, and ankles, and that's because of the high pressure areas. Arthralgias, so maybe a limp if it's in the lower limb, abdomen pain and vomiting due to inflammation, hematuria and bloody diarrhea, and then scrotal edema or subcutaneous edema. In terms of investigations, you can do a urinalysis, and it's often the only investigation you really require. So you can find hematuria in there, but often the hematuria is macroscopic, so it doesn't really matter. You can also get proteinuria. You can do a urine ACR to see how much protein there is, a UEC albumin, and then it's probably also important to consider ALL and ITP as a diagnosis. HSP is a self-limiting condition, usually gets better in around 4 weeks by itself, just needs a bit of bed rest and elevation to manage the edema, regular Panadol, and maybe ibuprofen in the short term. If the patient has quite severe inflammation resulting in abdo and joint pain, you can consider giving them oral prednisolone. And then close follow-up for a year, considering a renal biopsy for alternative diagnoses if relevant. So thalassemia. So most of this thalassemia presentation is through pictures because I do find it quite confusing. So we'll go through it. Epidemiology. So beta thalassemia is more common in your Mediterranean, Middle East, Central, South, East population. So I guess I would just remember the Mediterranean, and then alpha thalassemia is more common in Southeast Asia. So we've got 2 types. We've got alpha, which is the production of the alpha globin chain being deficient, and then beta, where the production of the beta globin chain is deficient. So we'll start off with alpha thalassemia. So I've said it's due to a deficiency in the alpha chain. It's caused by mutations in the alpha genes and results in an autosomal recessive inheritance pattern. Essentially, you have the deletion of alpha globin genes on chromosome 16. And you can have 4 different sort of presentations of alpha thalassemia depending on how many genes are actually defective. So to start off, essentially your hemoglobin, your adult hemoglobin usually has 2 alpha and 2 beta chains. but there's 4 types of globin chains. So you can have alpha, beta, gamma, or delta. The adult hemoglobin has 2 alpha, 2 beta. Fetal hemoglobin has 2 alpha, 2 gamma, and hemoglobin A2 has 2 alpha and 2 delta chains. So that's just all of that recapped. So if you have one defective gene, essentially what's happening is you're going to be a silent carrier with no symptoms, but you can still pass the gene onto your children. If you've got 2 defective genes, in that case, you've got alpha thalassemia minor, which is mild symptoms. You can have a cis deletion where you've lost the 2 copies of the gene on the same chromosome, or a trans one where it's on 2 different chromosomes, and that results in what populations it's common in. So the cis deletion is more common in Asian populations, and then the trans deletion is more common in your African populations. There can also be 3 defective genes, which results in hemoglobin H disease. So because you don't have your alpha gene, it results in excess beta chains. So you have tetramers where you've got 4 beta globin chains in your hemoglobin, and that's called hemoglobin H. And that causes hypoxia 1 through intramedullary hemolysis, and then also through extravascular hemolysis. And then also the hemoglobin H with the 4 beta chains, it has a very, very high affinity to oxygen, which means it stays bound to oxygen because it likes it. So then the oxygen is not delivered to cells as it should be. And that all results in increased red blood cell production, which can result in hepatosplenomegaly, and then bones containing bone marrow to also enlarge. You can also have the form where 4 genes is deleted, and then that's called hemoglobin Bart's. It results in hydrops fetalis. So essentially hemoglobin Bart's is 4 gamma chains, which has an even higher affinity for oxygen than hemoglobin H, which can also result in even severe hypoxia, and lead to cardiac failure, liver failure, renal failure, which is all leading to edema, and the hydrops fetalis picture. So in terms of the presentation, minor, moderate alpha thalassemia can result in pallor, shortness of breath, easy fatigability, skeletal deformities, and hepatosplenomegaly. Often the diagnosis for this is based off of blood tests to begin with. We'll show low hemoglobin with low MCV, so a microcytic anemia picture, with your blood smear showing similar things, as well as target cells and golf ball-like inclusions. But the actual diagnosis is going to be on hemoglobin electrophoresis, which, depending on which condition you're looking at or which type of alpha thalassemia you're looking at, will result in the elevated hemoglobin when you do it. And then you can confirm it with genetic testing. If they are testing fetal DNA, they can do amniotic fluid sampling or chorionic villus sampling, and test the genetic material that way. So in terms of treatment, mild thalassemia usually doesn't need treatment. Alpha thalassemia, non-transfusion dependent is alpha thalassemia intermediate and most hemoglobin H cases. Severe thalassemia will require blood transfusions, and if they have HB Bart's, which is the 4 gene deletion, they are going to be transfusion dependent, and they can also receive intrauterine transfusions and will eventually need a bone marrow transplantation. So that's alpha thalassemia. We'll just go over beta thalassemia, which is very similar. So you can have partial or complete beta globin chain deficiency due to a point mutation. The point mutation can be in a single nucleotide in a DNA, and it's replaced with another nucleotide on chromosome 11. And this often occurs in promoter sequences and splice sites, which will affect the way the mRNA is read. Essentially, you require 2 mutated copies to develop the disease. If you have 1 mutated gene, which codes for the reduced production or absent production of beta globin genes, you're going to have beta thalassemia minor. if you've got 2 mutated genes that code for reduced beta globin chain synthesis, you're going to have beta thalassemia intermedia. So that's why you've got plus because it's just reduced. Whereas if you've got 2 mutated genes that code for no beta globin chain synthesis, then that's beta thalassemia major. You've got the same sort of pathophysiology as alpha thalassemia, with the hemolysis resulting in hepatosplenomegaly and bone marrow enlargement. And then often what's happening with the heme is that the hemoglobin is that it's broken down into bilirubin and iron, which can also result in jaundice and secondary hemochromatosis. So beta thalassemia minor is usually asymptomatic. Beta thalassemia major, they're going to develop symptoms in the first 3 to 6 months of life. So with the beta thalassemia minor, you can get, again, anemia, hepatosplenomegaly, growth retardation, hemochromatosis type symptoms, so arrhythmias due to it depositing in the cardiac myocytes, pericarditis, cirrhosis, hypothyroidism, and diabetes mellitus. And then with beta thalassemia major, they can get chipmunk faces, hair on end appearance, and then that's associated with the crew cut. Most of the diagnosis is all the same as well. And then in terms of management, blood transfusions, and then beta thalassemia major is going to be transfusion dependent. If they've got really, really severe splenomegaly causing extra hemolysis, they might consider doing splenectomy. So we'll just quickly go over a few of the R3s, and then we can have a go at some questions. These are pretty much just going to be buzzword sort of questions. So we've got a nephroblastoma, which is a Wilms tumor. So it's a tumor that arises from immature kidney cells associated with Beckwith-Widman syndrome, which is an overgrowth disorder, Denny's-Drash syndrome, or Vago syndrome. Affects mainly children less than 5 years old. Clinical features. So often patients have an abdominal mass. It's unilateral because it's only on one side with the kidney, and majority of patients are asymptomatic. 25% of patients can have a hematuria associated with their presentation. They may also have intestinal obstruction due to the compression of the intestines, as well as hypertension due to the general renal dysfunction. Investigation-wise, we can do an FBE, UEC, LFTs, imaging, ultrasound, or CT, where you'll see the tumor. And then if they do biopsy it, they're going to see immature glomeruli, tubules, and stroma. Typically, management for this is nephrectomy and chemotherapy and radiotherapy. Often the way this actually works is that they will do chemotherapy first, and the chemotherapy will shrink the tumor. And once the tumor is shrunk, then they will actually resect it. And that's been associated with better prognosis for this tumor. So essentially, you've got an abdominal mass. It's not going to cross the midline, hematuria, and metastasis to the lungs. And then you can see the tumor here. We've got a neuroblastoma, which buzzword is raccoonized. So it's a neural crest cell tumor arising from sympathetic tissue, secretes catecholamine precursors and breaks down enzymes, commonly in the medulla of the adrenal glands. So in terms of clinical features, most likely abdominal symptoms, so large palpable mass midline, which can cause pain or constipation. Thoracic, you've got Dystonia-Horner's syndrome. It can result in spinal cord compression. 60% of patients are going to have burn mets, which can result in burn pain. Periorbital ecchymosis, which is the raccoon eyes, so just sort of bruising around the eyes, or bone marrow mets. And they can also have a weird paraneoplastic syndrome. In terms of investigations, I guess urinary catecholamines and metabolites are most important, as well as the homocyte rosettes. And then we can see the tumor here. So you can have, yeah, the lump in the abdomen, the lump in the chest, you can have bone pain and the raccoon eyes. We've got cerebral astrocytoma. So clinical presentation is typically headaches in the morning, feeling of being sick. Being sick often makes the headache. I'm not sure why I wrote that. Double vision, seizures, and fits. So often you can also have like morning sort of vomiting, headache. That's, yeah, worse in the morning, which is all the raised intracranial pressure symptoms. In terms of your classifications, you've got 4 types: pilocytic astrocytoma grade 1, diffuse astrocytoma grade 2, anaplastic astrocytoma grade 3, and glioblastoma multiforme is your grade 4. Majority of these are going to be low grade, and then of course your glioblastoma multiforme is quite serious. We've got medulloblastoma, so that's at the bottom here. It's the most common brain tumor of childhood. So 20% of all childhood brain tumors, most common in children between the ages of 3 and 8, slightly more common in boys than girls, associated with vomiting, which is often in the morning. Again, the raised intracranial pressure symptoms, headaches, clumsiness, difficulty with tasks like handwriting, especially because it's in the cerebellum, gradual decline in school performance. If it spreads to the spinal cord, it can result in back pain, difficulty walking, and problems with bowel and bladder control. So that's all in terms of the didactic teaching. We can do some questions if you guys would like. Maybe you guys can all just DM me. I might skip over these ones and you guys can do these yourself, and we'll just do the actual exam questions. Yeah, so you guys can DM me your answers. So a pale looking 2-year-old with widespread petechiae and cervical lymphadenopathy, which of the conditions listed below is the most likely explanation for the following clinical scenarios involving rashes? Yeah, I'll just wait for a few more responses. Okay. Okay. Okay, I think that's enough time. So I will, most answers were A, and I think the answer is A. There was a few H's. So ITP, I think the reason it's not ITP is because there's cervical lymphadenopathy. And then also if there's ITP, it might be associated with maybe a little bit more bleeding, as well as maybe a recent viral sort of infection. Someone also said G. Again, I think it's a lymphadenopathy, which is not G. You can't diagnose anything until you exclude ALL. This patient's pale, so anemic. 2-year-old fits the demographic, petechiae, thrombocytopenic, and then has got the lymphadenopathy. Someone also asked me a question: do we give factor 8 even if it's factor 9 deficient? Is factor 8 used for all hemophilia? Sorry, I just put that in because factor 8 is the most common and the one that you're more likely to be asked about. But if it's hemophilia B, you replace factor 9. If it's hemophilia C, you replace factor 11. So no, don't give factor 8 for all hemophilia. So an otherwise well 4-year-old girl who has developed petechiae on her lips and arms a week or so after recovering from viral illness. So I'll just give you guys all some time. Yeah, so everyone said H, and yeah, it's ITP. So we've pretty much only got thrombocytopenia symptoms following a recent ERT, which is why it's ITP. And then a 7-year-old boy with painful joints and a particular rash on his buttocks. Yeah, everyone's got it correct. So everyone's saying HSP, which makes sense. So high pressure areas, and then the painful joints are arthralgias. So HSP. This question can also be phrased in the way that you've got a boy that presents with abdominal pain and hematuria or something, and painful joints, and then that would also be a HSP presentation. So a 3-year-old girl has a recent history of weight loss, pallor, and irritability. She has periorbital ecchymosis and an abdominal mass and bone pain. FBE revealed evidence of bone marrow suppression only. Which of the above diagnoses are more likely? So I'll just wait for a few answers to come in, but this is very buzzword E. So most people have picked neuroblastoma, which I'm pretty sure is right. That's because of the periorbital ecchymosis, which is the buzzword for the neuroblastoma for raccoon eyes. A few people have picked E, which I think the only difference is that the periorbital ecchymosis picture doesn't fit, as well as the fact that these patients often don't get the pancytopenic symptoms. In terms of bone marrow suppression, I'm not too sure. Namik, do you know why there might be bone marrow suppression?
No, sorry, I don't think
Okay.
I'm.
Yeah, I don't know either. It'll be one to Google, or I can have a look for you and I'll let you know. A 3-year-old boy with a large unilateral palpable mass found on examination. That's carried out because of intermittent abdominal pain and a recent onset of hematuria. Yeah, so resoundingly everyone's picked Walms, which is right. So just go to the next one. 2-year-old girl examined by her uncle, who is a medical student practicing for his exams. He notes she's not clinically jaundiced, but has significant hepatomegaly. There's a history of multiple colonic polyps. Yeah, so everyone's picked hepatoblastoma, so I didn't cover this, but just good to know for onc. In the following scenario, yeah, so a 2-year-old boy presents to the ED with a history of recurrent nosebleeds and parental concerns around increasing pallor and lack of energy. His FBE is as following, so you guys can interpret it. And in terms of the previous question, so neuroblastoma and bone marrow suppression, the internet says that cancer cells can metastasize essentially to the bone marrow, resulting in the bone marrow suppression. I'll wait for a few more answers. I've only got one for this one yet, so. Okay. Okay, sure. So majority of the answers were A, which is right. There were, I think, a few I's. The reason ITP isn't right is because the hemoglobin slur and the white blood cell count slur. So ITP is an isolated thrombocytopenia. I think there might have been a C for this one. Again, same reason. The hemoglobin's low. We don't have an MCV, but the white blood cells and platelets are also low. So really want to exclude ALL. And then someone asked, how do we differ between A and B? So I think you're right. Aplastic anemia would also result in pancytopenic symptoms, but I think I've seen in pediatrics aplastic anemia, or maybe in adults too, be associated with a sort of infection at times, such as parvovirus B19, and then also common, I guess, white blood. Oh, sorry, white blood cells is high, which is consistent with ALL. That's my mistake. But that's due to immature white cells, which is why it's high. Your actual mature white cells, such as your neutrophils, would be low, which would result in frequent infections. I think all of these patients are definitely going to get a bone marrow biopsy, which needs to show more than 20% blasts. I don't think a blood film is sufficient to diagnose ALL. You'd need a bone marrow biopsy as well. And they'd also get a lumbar puncture at diagnosis. Next question, a 3-year-old is being investigated for possible celiac disease. Hemoglobin electrophoresis is normal, and his FBE is as follows. Yeah, so I think most people have picked J iron deficiency anemia. So the hemoglobin's low, the MCV is low. Main causes of microcytic anemia are iron deficiency and thalassemia. In this case, hemoglobin electrophoresis is normal, so that excludes thalassemia. So it's more likely to be iron deficiency. Anemia, someone picked B, aplastic anemia. Aplastic anemia, again, would result in all of these being low. Yeah. A 4-year-old girl with a history of a recent viral ERT presents to ED with bleeding from her gums and a particular rash on her arms. She's otherwise well. Yeah, most people picked ITP, so you've got an isolated thrombocytopenia. Yeah, that's it. I guess the only thing that I would really recommend is going through these for some buzzwords. But let me, are there any questions? No? Okay, sorry for the couple of mistakes I had in there, but I hope that was useful for you guys.
Thanks for that, Nikita. That was really good. Thank you.
Bye.
I'll send you through any questions if I get any. We
Yeah.
might just go to a break now before our next presentation. So we'll just give you guys maybe like about 5 minutes and then we'll come back. Thank you. All right, we might get started again then for our last presentation before lunch. Our next presentation is endocrinology and renal, and Akil is going to take us through that. Thanks, Akil.
No stress. Hey guys, how you doing? Let me just try and sort this out. Can you guys see slides? Preferably, or have I shared the wrong screen?
We can just see everything on your computer, including the slides.
Oh, that sounds quite depressing. How did I manage to do that? Wowzers.
No.
Do you have any
Now,
idea?
now we can just see your a 2020 SPOR exam kind of.
Oh, that sounds like even better. Bear with me for 1 second. Let me try and fix this.
That's all right. Take your time. No rush.
Maybe round 2 works a bit better. There we go. Does that seem to work? Nope.
Yeah, we can still see your slides. It's just the whole thing. Yeah.
Oh, you mean it's not in the PowerPoint view? Like you can just see.
Yeah.
Okay, I haven't pressed the presenting thing yet. Okay, cool. So if I do this, does this work? And if I move that over here, does that
Yeah,
work?
that's great. Yeah.
Okay, great. Exceptional. Sorry for the slow start. Nice to meet all you guys. My name's Akil. I'm a final year in Bendigo. I think I might have spoken to some of you guys before, but if not, feel free to say hi. So endocrine and urology / nephrology is a lot. This isn't your exact matrix, but this is what I think is basically covered in everything in your matrix. It's one of the older ones, and they often still ask about ambiguous genitalia, growth hormone deficiency, a bunch of other random crap. But yeah, let's see how we go. So first of all, let's start with the big endocrine one, which is diabetes. Also, feel free to stop me at any point if you guys have any questions. Just speak out loud. That's probably the best way. Okay, yeah. So what is diabetes or at least the one that we're going to talk about? Mostly we're going to talk about type 1 diabetes, which is autoimmune destruction of the pancreatic beta cells, which leads to zero insulin production effectively. Usually there's a genetic predisposition and a trigger, and you guys should know the clinical features: polyuria, polydipsia, weight loss, fatigue, failure to thrive, and then often they can present in DKA as well, which we'll talk a little bit about too. Where have I lost my slides? Okay, there we go. So let's go into some investigations. What do? So we can do a dipstick, random glucose, fasting glucose. There are a couple of criteria for people to be in DKA, but I mean, largely if someone presents whether acutely or more in a chronic state, often parents might present, oh, my kid's having about 4 liters of water a day. This doesn't seem really pretty normal. So they're actually catching it a bit earlier now. Some of the antibodies you might need to know for an exam are GAD and IA2. So GAD is just essentially something found in beta cells, and IA2 is islet antigen 2, which basically means that you have antibodies against your pancreatic islet cells. This latter is found positive in 96% of patients, regardless of whether they're in DKA or not. So you also then, I guess, do fasting C-peptide, which is byproduct of insulin formation. So when pre-proinsulin gets converted to proinsulin, you normally have C-peptide form, but that won't really happen if you don't have any endogenous insulin production. So your C-peptide would be nothing or very low if you have low production. And then once type 1 is confirmed, often they have other autoimmune sequelae alongside of it, so you do a whole other screen. So some things I guess to consider when talking about insulin management, particularly important when you're actually speaking to the child and their parents, because they need quite significant education, which is why they often have prolonged admissions, because they need to be safe to go home so that they know vaguely, I guess, what's going on. So things that I guess increase blood glucose would be anything to do with stress. So anything that increases cortisol, which is a glucocorticoid, increases your blood sugar levels, and therefore anything that can stress you out can increase your blood glucose. And similarly, things which can decrease blood glucose are things that not eating enough, a lot of exercise, illness, increased use, whatever. So these are the type of things that you need to discuss, I guess, with patients before they get started. And then I guess in regards to chronic management, there are different types of insulin regimes. It's good to really know it. It's not necessary for example, but I just put it all up there for you guys, I guess, to vaguely and for interest. One thing is that eventually they'll often get an insulin pump, which is probably the gold standard. They're often expensive, but they're becoming cheaper and cheaper as time goes on. And since these patients will often be linked in with endocrinology and numerous multidisciplinary things, they have the potential of getting insulin pump, as well as in terms of monitoring their insulin, which is another very important thing. They do with glucometer, or you can also have blood sugar levels like on implant as well, that like a CGM, continuous glucose monitoring, which is also very, very good and very, very useful. Basically for kids, similarly to old people, you don't want to get hypo because that sounds bad. So you basically, the younger they are, the higher you tolerate their VSLs in terms of where you want them to sit. On top of that, they need the whole multidisciplinary thing for diabetes that you'd know for GP. So a diabetic nurse educator, nutritionist, GP, pediatrician, podiatry, nephrology, ophthalmology, and then they need the regular check-ins effectively as well. If not well controlled, the complications can be seen as below. I guess talking a bit about DK, so hopefully you guys should know DK fairly well. It's definitely an easy OSCE or something that can come up on exams. So I guess some of the things that meet the criteria for DK is they obviously need to be hyperglycemic, they need to be acidotic and ketotic. They're in the name diabetic ketoacidosis. Some of the investigations, VBG, formal electrolytes, blood glucose, ketones, which you check at regular intervals as per the RCH guidelines. Other things, just the general broad principles of management is fluid resus. They're extremely dehydrated almost always, so you always give them a rapid fluid bolus. Typically aim for, when you say fluid bolus, it's 10 to 20 megs per keg, but or sorry, mils per kilo. But given the complications of DKA being cerebral edema, and on the lower side, it's probably about 10 mils per kilo bolus. Other things is potassium. You don't want to have issues with potassium because that can kill them. Similarly with insulin, you actually want to get the glucose back into the cells and bring down the ketones. The ketones are something you don't really want raised. So yeah, other things to do is just regular review and good follow-up. Some of the complications are put in the bottom left. I hope you guys can see my little mouse, but they're often like a question on an exam is, oh, I've given this person a lot of fluids and they have a headache. What's going on now? Oh, they probably have some cerebral edema. Okay, cool. Please tell me if I'm going too fast. I'm trying to get through this rapidly because we've got a lot of stuff to cover. Next, we're talking about congenital adrenal hyperplasia, which is a bit more interesting in my opinion. So up in the top right here, you have like the steroid synthesis pathway, which I guess makes all those hormones. If we get along here, we've got a bunch of random stuff that we don't really care about, but we care about the 17A and 21 hydroxylase. So the problem is that it's autosomal recessive condition where this little, this little enzyme here gets a bit cooked. So that means progesterone and 17 hydroxyprogesterone can't convert to aldosterone or cortisol, which means the precursor, 17A, is raised. And that means that gets converted downstream to testosterone, which I guess explains everything that you see for congenital adrenal hyperplasia. So what you'll classically see if you do any investigations, you'll notice an increased 17A hydroxyprogesterone, mostly because it can't get converted downstream. And then you have the sequelae of a lack of aldosterone as well as a lack of cortisol. So in terms of lack of aldosterone, that means there is salt wasting. So you have hyponatremia, but then you have hypoglycemia. You have issues with your blood pressure and stuff as well. Similarly, you also have issues secondary to cortisol. So if you have a lack of cortisol, you have poor blood pressure. So this is they can, I guess, present theoretically in some adrenal insufficiency type of way. More commonly, they present in the ambiguous genitalia, and the more, on an exam question, they'll present with the ambiguous genitalia, to be honest. They won't really present as the classical stuff in an exam. But hopefully that what I talked about makes a little bit of sense. I wasn't just rambling garbage. But definitely present extremely unwell. So decreased blood glucose, blood cortisol, increased 17 hydroxyprogesterone, and basically you could do an ACT simulation test as well, and then you look at a UVC. Make sense? Cool. So management, they need daily hydrocort, and then plus minus mineralocorticoid supplementation. That'd be fludrocorticoid if they are salt wasting. Other things, blood glucose monitoring, preventing major stresses, ensuring they have adequate height support, I think. So yeah, I think that makes some sense, logical. But yeah, hopefully that was okay. We're going to quickly talk about hypothyroidism. It's quite similar, I think, to adults, except when they're presenting in more neonatal period. So I guess the classic signs is a good differential when someone has prolonged jaundice in the neonatal period, poor feeding, faltering growth, large protruding tongue, coarse features, hypothermia, and bradycardias. So I mean, the investigation raised TSH, assuming, depending on whether it's primary or secondary, you'd anticipate if there's actually a problem with the thyroid gland, they have a raised TSH as opposed to a hypothalamic insufficiency. The management, give them thyroxine, and some of the complications are impaired intellectual development as well, in poor growth. Other things is that, I guess, to do with when we talk about hypothyroidism, probably talk a bit about hyperthyroidism. And with hyperthyroidism, essentially, you can get, it's the same as adults, but you can get neonatal Graves' disease, mostly because the maternal antibodies can get put into baby's bloodstream, and that can lead to a bit of developmental delay if not treated. Yeah, cool. Next, we'll talk about all the nutritional deficiencies. So I'm sure someone who spoke about hematology, who spoke about iron deficiency, anemia, is very common. So basically, after 6 months, they should be on solids, and otherwise, if they're just on breast milk and cow's milk, they just don't have enough iron. So it's not good. They present tired, growth defects, whatever. I think the other ones to talk about are vitamin D, B12, A, and vitamin C. So vitamin D will essentially lead to rickets and problems with bones. So if you think of the word orthopedics, the original actual like Latin name of the word ortho, to straighten, pedics for kids. So the whole goal of orthopedics was to fix rickets originally. So essentially you get the bowing of the legs, delayed closure, delayed issues with everything to do with the bone. And some of the investigations is vitamin D, calcium phosphate, parathyroid, UECs, sometimes x-rays, whatever. Long story short, they need vitamin D supplementation. And if someone's a preemie, you should really be supplementing them with vitamin D as well. Another thing, I guess, to know. I guess it's pretty rare in Australia, vitamin D. If people don't go outside very much, or they have poor nutrition, their bone can remain unmineralized and the bones kind of fray. B12 deficiency, common causes malabsorption, exclusively breastfed, or pernicious anemia. So anything that causes like a terminal ileitis where B12 is absorbed and some malabsorption there can lead to B12 deficiency. So that's a lot of the megaloblastic anemia, some neuro issues, failure to thrive, poor feeding, regression. What do? Give them injection with cyanocobalamin. Then vitamin A, a much rarer, I guess, nutritional deficiency that I guess you guys kind of need to know. Classically leads to night blindness. One of the leading causes of blindness in the developing world, not necessarily in places like Australia though. More commonly due to extremely restrictive diets. So things to do with eyes. So eat your carrots, I guess. Vitamin C deficiency can lead to scurvy. Also needs quite a restricted diet to be vitamin C deplete. Also, people who require common blood transfusions regularly or have sickle cell or thalassemia are at a greater risk of having vitamin C deficiency. They present with weakness, anemia, and then the mucocutaneous features, which is like the bleeding gums, the skin hemorrhages, and then the very iconic hyperkeratotic papular rash on their shins. Well, I hope that makes sense. Although we see how I'm going for time. Okay, I'm not talking too much so far. Okay, cool. Now we're gonna, I guess, I've got a couple slides here on normal development, more so for a reference. But this, I guess, leads to, and we're going to talk a bit about obesity, puberty, and then pubertal delay, as well as growth. So I guess obesity is classically defined as greater than 95th percentile for their weight. And then another thing for an exam to know is Prader-Willi syndrome is genetics, where they have hypotonia, insatiable hunger, intellectual disability, and they are markedly obese. So one thing is that the more people eat, the more people grow vertically in terms of height. So that when you actually consider what's going on, you should look at their total growth chart and see whether they have short stature, developmental delay, any actual developmental delay. And as for the RCH little framework here, you screen for comorbidities if someone's obese, overweight, and then obviously the goal is to try and bring them back down to a healthy weight, because there are some bad sequelae of obesity, as you guys would know from GP. Actually monitoring for the sequelae, so things like lipid, blood sugar, things like that, are important as well. Although the first line is always dietary modification, physical activity, along with some psychosocial support, since there are often comorbid mental health concerns with obesity that may or may not be addressed. And they're important to get done. Okay, cool. Speaking a bit about normal puberty, the words that I guess you kind of need to know are menarche, thalarche, and adrenarche. So menarche is the first menstruation, thalarche is breast development, adrenarche is dependent on your adrenals, testosterone, but therefore adrenarche. Yeah, so it's development of their secondary sex characteristics. For girls, usually it's in between 10 to 14, it's the start of breast development, and pubic hair, and axillary hair, and then menstruation, the last thing that occurs, so 2.5 years after onset of puberty, and then fertility rapidly develops. The pathophysiology of it is like the FSH and LH, which you guys should vaguely know. And then when we talk about boys are a bit later than girls, and then they often are fertile by the onset of puberty, slightly differently to girls. Other things, I guess, that's important for both of them is that they have growth spurts, change in the weight, body composition, maturation of their whole cardiovascular system, emotional changes, increased activity, increased sweating. So lots of discomfort, and it's a pretty challenging time for everyone. I mean, everyone can probably remember how they were during puberty, which probably wasn't great. But now speaking to the meat and potatoes, so let's speak a bit about expected height and then growth hormone deficiency. So in terms of what someone's predicted height is, it should be mid-parental height +7 for boys, and then mid-parental height -7 for girls. And if you think anyone's got short stature, any developmental delay, anything to do with growth, just plot the growth. And then depending on whether it's falling off centiles or whether the growth is fine, then you might consider whether there's an actual issue with growth, or whether it's just constitutional growth delay, as in it's just going to take a couple of years to catch up, or is there a growth hormone deficiency? So if they're below 3rd centile and their weight is normal and they're growing otherwise fine, and their bone age is essentially fine, then yeah, cool. Other concerns in normal puberty have to do with acne, gynecomastia, which can be transient in males, but lasts up to 1.5 years. Longer than that is a bit unlucky, and then we have to, I guess, investigate a bit more. Then obviously more likely to have anemia, SCI, scoliosis, visual changes, MSK injuries. So MSK injuries, whether you're thinking, depending on your weight, you might think of Sufis or whatever, and then some dysfunctional uterine bleeding, particularly at the start of menarche. So the way you assess puberty is through the Tanner stages, and then with a history as well. So growth chart compared with pubertal parents' pubertal development, and then whether or not there are any issues. So we're going to quickly speak about precocious puberty, particularly in the setting of obesity. So precocious puberty is just early puberty. Slightly more common in girls. And then there are central, peripheral, and benign causes, which I've got a whole table, which I'm not going to talk about. But long story short, I would recommend knowing that obesity causes central precocious puberty. A lot of other peripheral benign causes of pubertal delay, so that whether that's hypothyroidism, adrenal pathology, other syndromes. And similarly, if there's central things, it's a problem with the actual GnRH agonist. So I guess the thing with obesity that you need to know is that typically obesity, there's increased amounts of leptin. Leptin is your satiety hormone. And often people with obesity have leptin resistance, and then leptin affects your kisspeptin stimulation, and kisspeptin are some of the neurons and stuff that affect your GnRH, that pulsatile GnRH secretion. So too much leptin, not enough, or excessive kisspeptin, early GnRH, whatever. I hope that makes sense. With delayed puberty, I guess things to know is you would expect to see testicular enlargement after 14 years in boys, and then breast development more than 12 in girls. So some of the things I guess you would consider are whether it's primary or secondary hypogonadism, and then we've also got the same type of investigation, I would just recommend you guys have a quick look later. And then I've also got slides on here for primary amenorrhea for you guys to talk about later, but I think this is a bit more of a women's thing, but can be relevant in terms of the questions. So think of Coleman's, another classical one, hypothalamic, hypogonadotrophic, amenorrhea secondary to diet restriction and excessive exercise. And then obviously you think of prolactin. And then I guess the reason I actually had this on here was the uterine causes, because those are often questions in women/kids, where they talk about whether is this person have Mullerian agenesis, androgen sensitivity, CAH. So I guess the thing is to differentiate the few is that if they're Mullerian agenesis, they're classically 44XX, and there's an absence of the uterus, but they have normal ovaries. So menarche is the only one that's affected, because if you remember, like the Mullerian hormone just got to do with actually expanding that whole, like I think vaginal tract, something along those lines. And without that, they still have ovaries and other characteristics of puberty, but just no menarche. Whereas androgen insensitivity, they're XY genetically. They've got functional gonads produce testosterone and AMH, but peripheral tissues are insensitive to testosterone. So that means that, oh, whoops, Daisy. So they develop female secondary sexual characteristics because testosterone produced by the testes gets converted to estrogen because the peripheral tissues are essentially not uptaking them and there's no use for them. Therefore, estrogen gets actually used and they develop this secondary female sexual characteristics. Other things to know, intravaginal septum, pregnancy is a great cause of amenorrhea, not necessarily primary, but yeah. Those are the other ones. We're going to skip that one. You guys can have a look at that in your own time. And how are we going for time? Okay, 27 minutes. I haven't been talking for too long, I like to think. When we think of nephrology and urology in a kid, we're basically always thinking of a UTI. So UTI, extremely common bacterial infection of urethra, enterobladosis cystitis. And in neonate, you're thinking E. coli proteus. And infant is basically expand your microbial spectrum. And then it's basically always E. coli, if that's what you think. And then to be honest, it's quite common. 1% will have something at almost all times. And it's usually more common in girls, particularly after they're out of nappies. To be honest, even for a boy to get a UTI is still pretty rare. But we just worry about it in peds because it can quickly spread and they can quickly get very, very, very sick. Cool. So obviously the features depends on the age. So neonates, fever, any sick kid basically needs a negative urine dip or a negative urine specimen to rule out UTI. Infants, acute illness, fever, non-specific diarrhea, vomiting, abdo pain, immature voiding pattern, still quite difficult to differentiate whether or not they actually have true continence and control of their urinary tract yet. Child, usually they'll be able to discern whether or not they have some urinary symptoms, abdo pain and continence, and then you'll be able to, I guess, better discern what's going on. So I guess, how do I actually get a urine sample? It's probably a good question. So you got the option of in and out catheter, a urine bag, a clean catch, and an SPA, suprapubic aspirate. Basically, you want to do a clean catch unless they're extremely unwell. Urine bag, not great, really, just too much contaminants. And an in and out catheter can be a bit traumatizing. Still has some degree of, I guess, contamination, but I guess if clean catch fails, you can theoretically go to in and out catheter and then do an SPA if they're really unwell. Theoretically, dipstick doesn't diagnose UTI. What happens in practice? They've got leuks and nitrite, so they get started on something already. Other investigations you would consider depends on the age and how unwell they are. So if they're very unwell, full septic workup, and otherwise probably just go away urine MCS. So if they need to be kept as an inpatient, so if they're unwell, septic, suspected pyelo, or any person with a UTI under the age of 3 months, they are for inpatient treatment, inpatient antibiotics, IV benpen and gent. You can do gent level. Often one off doses of gent can be enough given how it's got a 7 to 10 day half-life. It's a very long-acting drug. But if they are well and don't meet the criteria, you can just give them Keflexin, pretty much. For the total duration of 3 to 7 days for cystitis, and then if they've had a pyelo, they need 7 to 10 days total duration. Obviously, if they're hypertensive, give them fluid resusc. and work through your doctor's ABCD if it happens to be an OSCE. Other things of note is providing good parental education, letting them know what a UTI is, how to recognize it, when to present, how to manage it, and then also particularly for girls, ensuring that, or preventing, I guess back to front wiping, ensuring that's front to back, to prevent the cross-contamination. Then I guess some other things for follow-up for a UTI is that all kids below 3 months with a UTI are a bit controversial, may need some follow-up. But basically, if they're less than 3 out of 12 months and a male, they definitely need an inpatient renal ultrasound. If they're seriously unwell or had any renal impairment, they need an inpatient renal ultrasound. And if they've having recurrent UTIs, they need outpatient non-urgent renal ultrasound to essentially, I guess, investigate the cause and to kind of figure out what's going on, whether there's any renal impairment, things like that. I've got some of the investigations you can consider on the next couple of slides. So we'll talk a bit about micturating cystourethrogram, particularly when we talk about vesico-ureteric reflux. And then we've got some other really fancy, not really that fancy, but unique tests, I guess, that are done more in a specialist setting. I think they're kind of interesting, but I think it's probably because I'm a bit of a loser. But let's go on to vesico-ureteric reflux. So probably one of the most common urological abnormalities. So there's abnormality of vesico-ureteric junction, which leads to reflux retrograde flow of the urine back into the ureters and kidneys. So primarily due to posterior urethral valves, which is common in boys and bilaterally. And this can lead to bilateral hydronephrosis, poor urinating stream. The classic exam finding is the lock and key appearance in ultrasound and a keyhole sign prenatal ultrasound. Other things are avoiding issues, bladder dysfunction, as well as recurrent UTIs. So if you think someone's got recurrent UTIs, you might consider vesico-ureteric reflux. One of the things is it's not very well diagnosed in ultrasound, which is why you do the test of micturate. Oh, good grief, I can't even say it. Micturating cystourethrogram within 6 weeks, usually, of their UTIs. Most resolve as the bladder grows, but I guess the management has to do with preventing infections and reducing renal impairment. So that can be antibiotic prophylaxis, so whether it's Bactrim prophylaxis, and then regular surveillance, and then surgical management if it doesn't resolve. Most of these kids will be linked in probably with pediatric nephrologist if they do have significant vesico-ureteric reflux. Cool. Now, I guess let's talk a bit about enuresis. So that's nocturnal enuresis classically. So that's just involuntary discharge of urine. Most of the time, it isn't problematic until they're getting past the age of 6. 4, 5, 6, you just expect them to slow down. Once it's getting past 6, 7, 8, it's starting to have a large psychosocial impact on not just the parents, but the child as well. So that's one aspect if it's primary. If it's secondary, it's almost always a problem. So let's talk a bit about what are the causes of enuresis and incontinence. So I guess functionally, stress, anxiety, drinking too much before bed, not toileting, behavioral issues, as well as certain medications can lead to nocturnal enuresis. This is more your primary issue. So if someone has present and never been able to not void, then you're thinking more along the lines of that. Similarly, if they have any diabetes, polyuria, constipation, UTI, when someone comes in with nocturnal enuresis or enuresis, you kind of want to rule them out. You guys might learn the DIPERS acronym next year for your reversible causes of incontinence, particularly in the elderly, quite similar in the kids, if you believe. Another important cause of secondary enuresis or incontinence is bullying at school. So you have to do a proper head screen and a proper history, but that's another common cause. Other different things are spinal cord abnormalities, abnormalities of the bladder. So I guess that's not necessarily enuresis, more so incontinence. So what do we do? So let's do a bladder diary. We need to essentially see how much urine production is happening, because they may or may not need desmopressin therapy, which is synthetic ADH. And then we look at their behavior, try and do some diet modifications. They're above 6, we do the bedwetting alarms. And then you use the star charts as well. And then essentially if those fail, you can start giving desmopressin. So you give it to them at night, a couple hours before they go to bed. And essentially that's going to reabsorb most of the fluid in the collecting duct and therefore prevent them from actually peeing out more. Can be useful. And desmopressin is also useful, I guess, in kids when we're talking about diabetes insipidus. I guess it's vaguely renal and endocrine. But if we have time at the end, I'll talk about it because I don't necessarily have a slide because it's not really that important. Cool. Now let's get on to the GNs. So in kids, if we're thinking of a nephrotic syndrome, it's basically going to be minimal change disease on an exam, unless you've got something else which is cool going on. So that's by the triad of edema, proteinuria, hyperalbuminuria, and plus the extra one, hyperlipidemia. So classically minimal change disease, focal segmental, a third remit, a third relapse on occasion, and a third very frequently relapse. It's essentially how the prognosis goes when you're speaking to parents. So what do I do for investigations? For their urine protein, they're going to have high urine protein. They're going to have low BP because they're intravascularly depleted. So essentially the problem is they're peeing out all their protein. They have no oncotic pressure within their blood vessels to hold in all the fluid intravascularly. Therefore, it third spaces. So they have a low blood pressure. They have all the edema, and along with they're peeing out all the protein as well. Okay, cool. So most of the time their UVC is normal, the LFTs are normal. They might have some abnormalities in clotting, and they have an increase in lipids. Renal biopsy depends. We'll see whether or not you do renal biopsy. Not always. So I guess some of the big complications about it are infections. So SBP, similar to adults, you're worried about spontaneous bacterial peritonitis due to ascites. So you just leave a bunch of fluid living in the tummy. Something's going to grow, commonly going to be gram-negative, and they're going to be treated with like ceftriaxone and gentamicin, which sounds pretty terrible, doesn't it? Then another thing got to do with their intravascular hypovolemia. So the tachycardic postural hypertension, dizziness, they have an increased hematocrit, and often you do need to fluid resuscitate them with intravenous 20% albumin because that's what they've lost. They're also an increased risk of thromboembolism and some cellulitis of the edematous skin. As you can see in the top left there, that's a little triad issue again. Okay, let's go talk about the types. So minimal change disease, unknown cause, usually doesn't progress to chronic kidney disease, and that's the effacement of food processes. Focal segmental glomerulonephritis, most of the time is idiopathic, and they are the ones that don't respond well to steroids. Most of the time, what happens is you give a kid steroids, handball them home, and they just haven't improved with any steroids. And this one progresses to chronic kidney disease and requires much more significant follow-up and requires pediatric nephrology, and they might be on Tacro or some proper immunosuppressants then. Then you also have membranous, which does respond well to steroids. It's the most commonest in adults. So how do I manage it? So let's try and reduce fluids. So strict fluid balance, daily weighs, fluid restriction, 20% albumin, relieve the inflammation to give them some steroids. So high dose pred, RCH is 4 weeks and then slowly taper off. And then you need some regular follow-up as well. So I guess the indications as well, you consider diuresing them sometimes, not really very often. Basically the intravascular volume deplete, severe symptomatic edema, then I guess you can give them some intravenous albumin and then consider some furosemide alongside to try and speed it up, but that's controversial. Other things to do is they are remitted where they have no producing urine for 3 consecutive days, and then the family are supposed to test the urine very, very frequently. And if it doesn't improve with steroids, that's when you do the renal biopsy. They often do have relapses though. Now let's talk about nephritic syndrome. So nephritic syndrome are hematuria, plus minus some mild proteinuria, hypertension, and then classically post-infectious strep, IgA, and then some Alport syndrome is another one. I guess slightly different pathophysiology. Essentially, the way I think of it is something is now blocking and hit the tubules and the little nephrons and the, the glomerulus. So nothing can go through very well. So because shit can't filter too well, they're hypertensive because they've got overload in their intravascularly. They've got hematuria because they're just peeing out blood secondary to the damage that actually happens to the kidneys. And they get a bit of proteinuria because it gets a bit weakened. They also get oliguria because this is often a damage to the kidneys. So yeah, probably not as good. So what I guess are the common causes? Post infectious strep is pretty much the big one. The most common one is strep pyogenes, and it's like the IgG immune complex deposition. Typically 1 to 2 weeks after a throat infection, or 3 to 6 weeks after a skin infection, whether depending on what it is, whether that's scarlet fever, whatever. So some of the complications: AKI, short-term dialysis if needed, hypertension, and then the test you need to know is an ASOT with an anti-streptolysin titer, and they can do streptococcal DNase B, and then they have a low complement as well. Most of the time, they actually can resolve within 10 days, but they need a fluid and salt restriction and then some steroids. Another cause of nephritic is IgA. So discerning between IgA and post-strep is another common question. The thing is that it is synpharyngic, usually 1 to 2 days within the same time of them having a UTI. So it's progressive decline in renal function and can actually be quite terrible and lead to chronic kidney disease. And then there's episodic frank hematuria. We will speak about HSP on another slide, so don't worry. But that's a little bit about it. Then I guess the management is admit them, fluid salt restriction, fluid balance chart. Don't normally give diuretics because all you're going to do is really crank the kidneys worse, and you can give some steroids and consider antibiotics post-infectious. Doesn't often happen. Another one that we often see on an exam is Alport syndrome. So that's an X-linked dominant condition where they have issues in type 4 collagen. So that is just bilateral sensory neural hearing loss with hematuria, essentially. If someone has bilateral sensory neural hearing loss and some microscopic or macroscopic hematuria, just think Alport syndrome. You don't need to know more than that for an exam, really. But yeah. Now we're speaking about HSP. So HSP, small vessel vasculitis, properic rash, and can cause the nephritic syndromes that we spoke about. So basically, if someone has suspected HSP, they often have that rash as seen below. Classically, the feet, the buttocks, the inner thighs. And basically, you do urinalysis, blood pressure, and if they've got either of them are abnormal, they probably need some additional investigations and some admission for some steroids and joint pain. Do you always give steroids? No, you usually give steroids if it is actually severe enough. So I guess, what does severe really mean? Typically, if they're having very, very bad persistent hematuria, anything where you think they're quite systemically unwell or aren't able to tolerate the lower grade things of paracetamol, NSAIDs, things like that. There is an RxAge guide on it. I would recommend having a quick read of that. It's not very long, but can be useful. Other thing that's important is that they've got quite extensive follow-up to essentially ensure there's no subsequent renal involvement. So you essentially weekly for the first month, they do a BP urinalysis, and then fortnightly from 5 to 12, and then once in 6 months, once in 12 months. And then if there's any flares, you go back to weekly reviews, or if there's renal involvement, they need more regular reviews and pediatric nephrology involvement. Now, I guess we're talking a bit about the penile abnormalities. I think that's what I'm supposed to talk about rather than the surgeons or whoever the surgical guy is, but we can talk quickly about
They covered it briefly in their presentation, but feel free to go through it if you've got like 20 minutes left. So like happy for you to go through it too. But if you have other stuff you want to cover, that's fine too.
Not really. I mean, I've got the slides here on it, to be honest. But in that case, we can probably talk a bit more about some nephrology stuff rather than me having to go and race through it all again. I'm sorry that I went so quickly, but hopefully that was vaguely useful. And let me press escape. You guys can see all of this. And now the one thing I want to talk about is desmopressin stuff and talking a bit about diabetes insipidus. So diabetes, I guess, comes from the Latin name, pass through. Mellitus used to mean sweet because they used to test the urine and taste it. Insipidus essentially means it's not tasty. It's not tasty because there's no sugar in it. So the problem with diabetes insipidus is classically poorly concentrated urine. Okay, so whether it is central or nephrogenic, there is inadequate response to ADH or vasopressin. So antidiuretic hormone acts in the collecting ducts to essentially reabsorb water and help concentrate the urine. So that helps with blood pressure and actually preventing polyuria. So in terms of central diabetes insipidus, you would realize that they just have no ADH production. So if you give them some desmopressin, they respond, and their urine-specific gravity as well as their urine-specific gravity and osmolality improves. Whereas if they have nephrogenic diabetes insipidus, they don't respond well to desmopressin. So if someone's got a lot of polyuria, a pretty low urine specific gravity, you're thinking of the lines of diabetes insipidus, and then after you do that, you do a desmopressin response test, or a desmopressin challenge. So you give them some water. A couple of hours later, you give them some desmopressin. A couple of hours later, you check their urine. So basically, you do their specific gravity at the start and then later. And if it's improved, they've had a response to desmopressin, which means they probably have central diabetes insipidus. And if they haven't, they've got nephrogenic, and that's a whole other can of worms. The reason I guess I mentioned that is because if you're talking about diabetes and polyuria, polydipsia, another good differential to have is diabetes insipidus, and that does actually happen. Because I managed to finish early, is there any parts of the presentation someone wants me to talk about more? Because I can talk about them a bit more. But yeah, otherwise, I hope that was vaguely useful. You guys will all smash your exams. You guys are all pretty good, pretty smart kids, so you'll be fine. Yeah, I'm gonna open the Zoom to see if there's any questions. You guys can just put it there. Whoopsie daisy. I am waiting for my Zoom to load. So I've got a question. Is the lock and key sign for vesicoureteric reflux or posterior urethral valves? The lock and key sign is classically more of a posterior urethral valve. Sorry if that wasn't clear, but I think just because you can more likely see that they might have, if they've got posterior urethral valves, they are more predisposed to vesicoureteric reflux. But the gold standard is still the micturating cystourethrogram, which you ideally would do if someone has vesicoureteric reflux, or are having regular recurrent UTIs. Any other questions? That's a great question. To take that as a no. Okay. Maybe if no one has any more questions, people have my email. People can message me on Facebook or anything. Thanks for letting me do this, and I'm sorry I talk so fast and don't make any funny jokes, but hopefully someone else can make you laugh, and hopefully you learn something. Cool. Thanks, guys.
Thank you for that. And that was so much to cover in such a little time. So I feel like that was really good. And they have your slides on the surgical stuff too, so they can use both of that stuff to sort of study off of. So thank you for that.
No stress. Thanks, guys. See ya.
Thanks. We might go to a lunch break now, if that's okay with everyone. And did you guys still want to come back at 12:30, or do you think maybe 12:20? What do we think? Get it over and done with, or have a longer lunch? 12:30, 12:20. I'm getting 12:20s, 12:20. Okay, cool. 12:20 it is then. Cool. Thanks, guys. I'll see you back at 12. Just give people a few minutes to come back, and then we'll start in a sec. We might just get started then, and people can just join as they sort of filter back. So I'll take you through some dermatology and infectious diseases, and how I've just sort of structured this is mainly just for around exam questions. The main sort of thing you'd get in an OSCE for a rash or anything derm related would probably be either Kawasaki's disease or asthma, which I'm sure you're all across anyway with asthma from GP. Things like measles and slap cheek disease and roseola and things like that are unlikely to present for an OSCE because it just seems like they're a little bit niche and they're not going to waste the whole station on just something so small. So these questions are just mainly focused around your written exams. Yep. And I've just kept it all super brief because like at this time of the year, you just want the stuff that's just going to get you the marks as opposed to just a more generalized understanding of the disease. So if you just go through this first question and just sort of send me a few messages about what you think this might be. Yep, perfect. Cool. Yep, so that's measles, and the way that I sort of remember this are the 5 C's. So coryza, Colpic spots, even though it's with a K, cough, conjunctivitis, and yeah, and then there's a rash as well. So just with this one, you can see in the corner, sorry, I'll move that across, with the rash. So on our exam questions, it was usually, we didn't get many pictures of rashes. It was mostly just a description of either the rash. It would say like, this child has a blanching erythematous maculopapular rash with sort of white spots on buccal mucosa, and then you had to make a diagnosis about that. Whether or not you want to spend time understanding or trying to remember the pattern of infection, so how it spreads and when the rashes are infectious and things like that. I don't know if I haven't come across many questions where it's asked for those specific details, but it's still good to, I guess, have some sort of understanding of. But in terms of management for a lot of these infectious diseases with rashes, it's usually just symptomatic management for children that are well. So fluids, paracetamol, and rest. Isolation from school for at least 5 days because it's infectious. You have to notify the Department of Human Services as well within 5 days. And if it's less than 72 hours since the child has been exposed, so in the question it will say something like, and they were exposed, they had a sick contact with something sounding very similar to measles 2 days ago. So therefore, it's still within the time frame. So then you give MMR, as in the vaccine. But if it's over 72 hours or they don't really know, then and it's still within 7 days, you just give IVIG in terms of the management. But most of these questions will be around a diagnosis. There won't be too many that require management. All right, similar sort of thing with rubella. The difference here is that it's a fine rash. It's non-itchy, and it starts on the face, then descends onto the trunk, and then onto the limbs of the child as well. Sorry, I made a mistake there. I've said very itchy and non-itchy. I'll fix that up in the slides. Sorry about that. And then the buzzword for that is these spots here, these Forsham spots that are particular hemorrhages on the hard palate of the child. And these can be painful. So one thing to sort of watch for is also oral hydration in terms of, I guess, fluids and food to make sure that the child's still getting what they need. Chickenpox, VZV, so small, and the buzzword there is, or the thing that will set this apart from the other, ones, is that it's crusted over vesicles that have ruptured. And the management for this is similar, but the main thing is using chamomile lotion for the itch to prevent itching and scarring. And they have to stay home from school until all the lesions on their body are crusted over. What do you guys think this one is? Yep, getting a lot of parvos. Yeah, perfect. So this is parvovirus B19 or slap cheek or erythema infectiosum or fifth disease. You have to know that you have to know that it can be called by all of those names, because sometimes that it might be fifth disease as an option, it might be slap cheek, it might be parvovirus as the causative agent. So you just have to know that, but it'll usually just be that it's a rash that's mainly sort of involving the face. It can be on the body as well, but the child sort of appears well, and you might get that sort of picture of a red lacy rash. This one, what do you guys think this one is? Yeah, foot and mouth. They give away that it's on the lesions are on his hands, his foot, and his mouth. So you have to know that that's caused by Coxsackie A virus. Hand, foot, and mouth is what it's commonly referred to as. And then the vesicles, or the rash, is primarily on the soles and the feet, and there's ulcerations in the mouth. But in these children, because of those mouth ulcers, they might be quite reluctant to eat or take in food orally, so they might need admission to the hospital if they're unable to eat or they're refusing to eat. Getting a few ones. Roseola. Yep, perfect. So this one is the classic thing of when you've fever that ends, the rash descends. And so that's this one here. There is, because the fevers can be quite high and can come on quite rapidly with roseola, you can get sort of febrile convulsions as well. And this is how the sort of rash looks. A lot of the pictures that they use in the exam, I'm sure the people from GP, that the guys that did GP lectures have told you this, but a lot of the lectures, a lot of the questions on the exam, if they're going to use a picture for a rash, they'll use the images from DermNet. So just familiarizing yourself with a few of those will be helpful. But anyway, not necessarily essential. As long as you sort of know what the rash is described as in terms of its medical jargon, then you'll be able to get away with most of those things without actually even needing to know what they look like. Yep. What about this one? Yep. Impetigo, Staph aureus. Yes, very good. Yep. So this one you need to know, like it's honey crusted lesions. There'll be a history of atopy or eczema that they've got. It's very infectious, so you've got to isolate them from school. and the management is sort of covering it with waterproof dressings to keep the skin hydrated, and they sort of scab and come off. But in terms of, you could be asked, I guess, if they could give you this sort of question and then just say the child is also unwell. So how would you manage then? So if the symptoms are if the child's unwell and the symptoms are sort of diffuse, it's everywhere, then oral flucloxacillin to treat the infection. But if the child is well, if the child is well and the symptoms are localized, then mupirocin would be fine as a topical sort of ointment/cream. But if left untreated, it can progress to cellulitis, septic arthritis, sepsis, and even death. So quite serious and requires treatment and monitoring. In terms of another sort of form of it, if these lesions or sort of eczema gets infected with HSV, then it can progress to like herpetorization of eczema. And that's a medical emergency because it predisposes these lesions to then concurrent infection with Staph aureus, and that can be really bad. So it usually requires some sort of treatment with oral acyclovir, if they're able to tolerate it. But if they're really sort of drowsy out of it and refusing oral intake, then IV acyclovir would be good as well, would be the next option. And if these lesions sort of involve the eyelid, then referral to ophthalmology, an urgent referral to ophthalmology is warranted as well. But pre-exam, just sort of know the management would be either oral or IV acyclovir. Yeah. Yep. Scarlet fever. Yeah. Okay, cool. Getting quite a few scarlet fevers there. And yes, the giveaway for that is that the rash has this sort of perioral sparing and the sandpaper-like feel. You could also hear it as sort of this goose flesh, and that's the picture there, the bottom right there. The rash is sort of blanching. It's this red boiled lobster appearance. That's how sometimes they describe it. And it's a red boiled lobster with sandpaper feeling skin. I know it's a strange sort of way to describe anybody's sort of skin, but that's just how they like to describe it sometimes. They can also have a strawberry tongue, like in Kawasaki's, but they won't meet the other criteria for Kawasaki's because remember how you have the high fever plus the 4 other criteria. So these children won't sort of present the same way as Kawasaki's, but it's a good, I saw a few people that said Kawasaki's. We'll get the Kawasaki's in a second, but it's a good sort of differential to keep in your mind. They'll also have these pastilla lines. So that's this here, if you can see my mouse, in flexural sort of surfaces. But yeah, the management for that is just oral phenoxymethylpenicillin. So pretty straightforward. Then there's asthma. I'm not going to go through too much through this because I feel like you probably would have covered this in GP, and you've covered this last year, and it comes up a lot. So like, it's probably a bit redundant to go through it over and over again. But it could come up in an OSCE, and that's probably the main way that it would present if at all for an OSCE. Sorry, I just have a question. Yep. Yep. So just important to keep that in mind, but it's usually itchy, dry skin, a family history of atopy, things that you're all familiar with. And it's in kids, or infants or young children, it's primarily in the flexor sort of areas. But then in terms of management, the main thing is sort of education as well. So avoiding things like overheating, making sure the skin's not dry, avoiding irritants, and then treating any inflammation, flare-ups or infections. And there's like a massive document on the RCH that has all that stuff. So I'd recommend if you worried that you might get this for an OSCE and you're not sort of familiar with it, this would be a really good sort of resource to sort of go through and familiarize yourself with that, just so that you can rattle off a few of these things in terms of your management. And usually it's when we had even practice OSCEs, or when you look through the OSCE stems for the previous years, it's sort of a quick diagnosis of eczema, and then the bulk of the station is around the management of it, because it's all about it. That station's purpose is to just sort of test your communication skills and how well you can convey that to a parent. But in terms of the management of eczema, pretty straightforward. You should have a look at the RCH for it. It has a flow chart. This score, I don't think you need to know in terms of severity, but because I guess the management depends on, if you look at the flow chart on the RCH, it has a thing about how to treat mild versus moderate and severe. But if the question says lots of things like there's severe erythema, there's swelling, crusting, if it has all of those features, then it's probably severe, and you'll be able to gauge that from how the question is phrased. Yeah, just sort of go through that, have that diagram in your head, and I think it's usually pretty straightforward if it comes up on an exam, but even for an OSCE, just sort of learning that. Yep, cradle cap. Yep, perfect. Yep, so cradle cap seborrheic dermatitis. Yep, so it's inflammation of areas with sebaceous glands in the body. And the key thing for cradle cap is this dandruff with a butterfly rash. You can see here on the bottom left, that sort of rash, and then the greasy sort of crusting on the scalp. It's self-limiting. You can use shampoo in kids, but the main way that you'd have to just sort of know, the main thing you'd have to know about this is that it's dandruff and a butterfly rash, and that's your diagnosis of seborrheic dermatitis. Yep, scabies. Yep, perfect. Great. So all you need to know about this is that it's usually in overcrowded families. It'll be very obvious that the child is living in sort of poor to overcrowded conditions. They'll usually throw in a certain population or demographic in there. Monash loves those kind of things, but it could be anyone. And then you just sort of say that they have vesicles on their palms, but then they'll also say something about either mites in the webbings of their fingers. So if it says anything like that, it's scabies. And you got to make sure that the clothes in the house are completely washed, including the linen, the sheets, all of that. And you just cover the person and their entire family in this cream, in permethrin cream. That's the management for that. Yep, lots of people saying Kawasaki is perfect. Yep, so this could be an OSCE, so it might be worthwhile just spending a bit of time familiarizing yourself with the criteria and the management plan for this disease. But it's usually sort of a young child of Asian descent, and they have a high fever persisting for 5 days, plus at least 4 of the following. So this conjunctival injection, which you can see here in the top right, a rash, oral changes, so that's your strawberry tongue, edema, cracking of the lips, and then also extremity changes, so things like really warm red peripheries, lymphadenopathy, but that's commonly sort of on one side, and it's usually in the neck. And the way that it's investigated is you can do this ASOT sort of anti-strep titers, things like that. But the main sort of investigation is an echocardiogram immediately, and then 2 weeks, and then subsequently at 6 weeks to rule out and make sure that there's no coronary artery involvement, because that's the main sort of complication in Kawasaki's that can lead to severe impairment and potentially loss of life. But the management is if the child presents within the first 10 days, then IVIG. But you can also consider IV methylpred if they're high risk, and the criteria for if they're high risk is if they're less than 12 months, if they're of Asian descent, or if there's coronary artery involvement on the echocardiogram that you perform when you make the diagnosis. And then you just treat them with high dose aspirin when they're febrile, because that fever is going to persist for a few days as well. I hope that makes sense. So that's all that I sort of had for derm. I'll quickly take you through is this Sorry, I might just ask the person that sent this question through to just repeat it. Methyl red. I'm not getting. Oh yes. So this is super rough. Like they wouldn't ask you to differentiate between it's 12 months or if it's a little bit over 12 months. Like it'll be very clear. It'll be like a 9-month-old. They won't give you bang on the cusp of 12 months and ask you how to treat that. But good question. Ruben Hines is a lot not nicer than I guess some of the people that write your women's exam. I didn't say that. I'll bring up your genetics now. 1 second. All right. So this one, really what you kind of need to know is for genetics, you just need to be able to make the diagnosis. I've never had an OSCE or seen anything where you have to sort of counsel on Down syndrome or anything like that in peds. You might have to do something like that in women's health or an antenatal station or something like that, but not for peds. The main sort of things to be aware of is that it's probably the conditions that these syndromes are associated with. Especially the R ones like Down syndrome and neural tube defects and things like that. But a lot of the other genetic conditions, you just have to sort of know the main features for it, and then that'll be fine. We actually had last year about 4 to 5 questions, and some of the questions were, I thought, were a little bit harsh. You had to know the inheritance pattern of the condition. So it'll talk about, it would say like, oh, this kid's got trisomy 18, rocker bottom feet, and polydactyly. What is the inheritance pattern for this congenital abnormality? So you had to know that it was like either autosomal dominant, X-linked recessive, or like X-linked dominant or whatever it is. So yeah, that was, I felt like that was quite harsh, and I checked with a few other 50ers to make sure that I wasn't inventing that in my mind. And yep, we definitely had questions like that. So it would be worthwhile just memorizing the inheritance patterns. But again, it's not going to make or break whether you pass the exam. So it's really up to you how much you want to memorize. But really for things like Down syndrome, you just want to go through the antenatal screening. That would be more women's health. And then after that, for peds, it's more so karyotyping, and that's the way to diagnose that. In terms of the symptoms, the main sort of one that comes up on the exam is these upslanted almond-shaped eyes with these folds, small sort of ears, mouth, and a protruding tongue. And in terms of their body, they usually have a single palmar crease. It's called a simian crease. That one comes up a lot. And a sandal toe gap as well. That one comes up too. But just knowing some of the features of these conditions will be enough to get you over the line for a question. In terms of neural tube defects, main sort of risk factor is folate deficiency or any sort of mechanism or medication that can cause reduced folate uptake, so or utilization. So medications like methotrexate, valproate, or trimethoprim that the mother might have been on at the time. And then you need to know the spectrum of neural tube defects. So going from something where it's just simple spina bifida, where it's like the main sort of symptom there is just a skin dimple or a collection of fat or a patch of hair. It's something you also check for when you're doing a baby check. The next one step up from that is a meningocele, and that's where the meninges herniate through the defect without any neural tissue going through. And then a meningomyocele, which is where the meninges and neural tissue herniate. And then the last one, which I have trouble pronouncing, rachiosis, which is where the neural sort of the spinal column itself doesn't fuse properly, and you get exposed neural tissue without any meninges or anything covering it. So that one's quite serious. But just having an idea of that will be good, and just knowing the different symptoms, what the different ways that they're defined. So fetal alcohol syndrome, the buzzword for that will be, it'll say that there was some amount of alcohol that was consumed, and we know that any amount is unsafe in pregnancy. And then it'll say that the child was born with, X and Y features. So it's just a really good idea to sort of memorize a few of these features. And the one that comes up a lot is this smooth philtrum with thin upper lips, up the nose, epicanthal folds, that kind of thing. So just knowing that and having a few of those features is a good idea. Plagiocephaly. So there's a really good fact sheet on the Muppets sort of website that goes through all of the deformities, but just I guess in terms of what you need to know for the exam, just know that it's usually caused by lying down for a really long time on the back of the child's head. So the way to sort of manage that is you first start off with changing their position in which they sleep, making sure that they have more tummy time and carrying them around. But you'll know if it's severe because it'll say something like, oh, they've tried all of these things already and it hasn't worked and it's getting worse, in which case then you trial helmet therapy. So that's just essentially what you need to know about it. You just need to know it's an asymmetrically shaped head. First line management is just changing position, encouraging tummy time, carrying the child, and then if that's failed, helmet therapy. And this one's just simply a diagnosis kind of question, but they might just say there's premature fusion of the sutures, there's bulging fontanelles, child is drowsy, there's some kind of neurology. The mother reports that the child's face is misshapen, she's concerned about the way that he looks. And on examination, there's fusion of the suture lines, and that's called craniosynostosis. I'm not going to go through all of these ones, but I think it's really good, and it's definitely worth your time to sort of go through these things and try and memorize them as best you can. And again, we can't say that it's going to come up again this year, but we had to remember the inheritance patterns. I don't know, do with that what you will, but it's all here, and I've put sort of the main features of each one that can be sort of identified. So how you can identify each condition. And there was a question yesterday about whether we had to know like Friedreich's ataxia versus ataxic telangiectasia. Yeah, I think you should just spend some time, if you do have time, like memorizing a few of these conditions. But that's all in terms of content. Did you guys have any questions about that? I do have some exam questions as well, and we can either leave it here or we can go through them depending on what you guys feel like. Getting exam cues, go through them. Yeah, we'll go through them. Lots of go through them. Yes, we'll go through them. What's this? What was the inheritance pattern for Noonan syndrome? Oh, sorry. Hi, what's the inheritance? Oh, for that question about the inheritance patterns, it would be for everything on that list. So like next to each one, I'd put a like a pattern of dominance. So if it was autosomal recessive, like I'd put AR next to it, or AD if it was autosomal dominant. So I'd recommend like memorizing it for all of those ones, because we had to. Cool. All right. I'll just share the screen for the exam question. And just bear with me, I've written these ones, so they're not perfect, but they should look a bit like the ones you'll get at the end of the year. Cool. So just send through those ones. They might take a bit of time, but that's okay. Yep, so I'm getting a lot of Ks. Very good. Perfect. So the reason that this is a ventral septal defect is because it stays in the question that it's a pansystolic murmur, which you sort of get in a VSD because the pressure in the left ventricle is always sort of usually greater than the right. So there's a constant pressure gradient pushing blood through the septal defect. It's the typical sort of symptoms of heart failure as well, where there's that buildup of fluid either onto the lungs, which is causing those recurrent infections. There's failure to thrive because there's reduced cardiac output, and also probably because of difficulty in feeding. So the child's having difficulty eating or being able to take in enough nutrients. Another thing as well is that they might go blue with eating or with anything that requires increased energy, because their cardiac output can't sufficiently maintain those increases needed to supply enough energy when they're crying or when they're feeding. So they might go blue when they're feeding. That might be something that you see in the questions. Does that make sense? Cool. All right, next one. Gosh, you guys are quick. How do you even read that so fast? Anyway, everyone's saying PDA, which is correct for this one. And the giveaway there is the continuous machine-like murmur, which I purposely put at the end, but you guys are quick. But there's also increased ventilatory requirements in this child as well, because again, they don't have the same amount of oxygenated blood because of the mixing as someone without a PDA would. Also good to know that these things are associated with things like Down syndrome, congenital rubella, maternal drug use, and then if mum was given prostaglandins during labor as well, that could interfere and keep the PDA open. So those are just things to keep in mind. And then the main risk factor here being as well that they're preterm. Cool. What about this one? Cool. I'm getting a lot of RSVs. Very good. Yeah. So for this one, the main thing is noting that it's the child sort of got a wheeze. It sounds like it could be asthma because the way that I think about it is the virus inflames the bronchioles and that causes excessive mucus and bronchial constriction, similar to an asthma. So you get that wheeze when they're trying to breathe out because there's airway obstruction. And then you just have to know that the causative agent for these things is RSV, or it's most likely to be RSV. Oh, someone's asked why the palpable liver. With hyperinflation of the chest, sometimes the liver can be displaced downwards, and you can sometimes get a palpable liver. It doesn't mean that there's hepatosplenomegaly in this child, but it just means that the liver's sort of displaced a bit more into the abdominal cavity as opposed to somebody without that increased inflation. And then we had a question yesterday about the difference between bronchiolitis and asthma as well. So just making sure that you guys sort of know that, because that's something they could ask about in an OSCE. Cool. What about this one? Okay, so I'm getting quite a few G's for parainfluenza and then a few J's for Staph aureus and a few F's. Okay, so with this one, the answer is actually Staph aureus for bacterial tracheitis. The reason that it's Staph aureus as opposed to normal croup is because the fever is quite high. They've had a dose of oral steroids which they haven't responded to, which is classic in sort of bacterial tracheitis, also known as toxic croup, caused by Staph aureus, as opposed to normal croup, where they'll usually if it's viral and it's due to parainfluenza, they'll usually respond to that oral course of steroids and won't sort of go this way. And Beatrice, in this question, you can see she's quite unwell. She's now she's not drooling, so there's no immediate sort of airway occlusion, but you decide that it's best to sort of escalate to a senior member of staff because you're worried about her airway. So this is sort of very common in toxic croup, and that sort of high fever is very indicative of more a bacterial sort of thing as opposed to as opposed to group. Does that make sense? The causative organism of toxic group is Staph aureus, but the causative organism of normal group is parainfluenza virus. Does that answer your question? Cool. All right. Nope, another question. Yep, cool. Oh boy. All right, what would be the next thing here? What would be your next step in management? Yes, exactly. So a few people said F, but a lot of people said D. The reason that it's not contact the surgeons is because it says in the stem that you are a pediatric surgical registrar. And I remember getting a question like this wrong on a practice exam because I didn't pick up that I was supposed to be the surgeon. So that's just important. Just read your role when you're going through these questions, because a lot of the times the questions will be, they'll have these extended options for multiple questions. So like, for the next one, it might be contact the surgeons because you might be the intern in ED, but it's just important to sort of recognize your role. So contacting the surgeons is a bit inappropriate when you are the surgeon, I guess. But I know that's silly, but it's been an issue before, so I thought I'd put that in there. But yes, providing NGT suction would be the appropriate thing to do here for interception. Oh, sorry, not interception. For malrotation. Sorry, my bad. Yep. Is that cool? Sorry to be mean and put that in there, but I just thought it's important. All right, what about the next one? Yep. So I'm getting quite a few E's and D's. So I feel like, yeah, they're both fair answers. The reason that it's E is because when you approach any sort of, I guess, child that's deteriorating or an emergency, you always go through your doctor's A, B, C, D's. And it is appropriate to contact the surgeons, but you need to, I'm sure you've seen from your time in ED or wherever, like if there's an emergency, yes, you contact whoever, but the point is that you medically stabilize the child first if they're deteriorating. Why not NGT fluid? Because they're vomiting. Yes, that's correct. So it's not appropriate because they'll just vomit it up anyway, and you're not going to give them antiemetics to sort of secure their circulation. So as part of that, the way that you'd go about that, yeah. Does that make sense? Cool. Yeah, someone said yes. Okay, cool. All right. What about this one? So I should have removed contact the pediatric surgeons here, but yes, I'll accept D and J. On your exam, you won't get both of those because that can be confusing because that's both fair. So you've identified that it's necrotizing enterocolitis, and that the management there would be the definitive management would be IV and antibiotics, but you would also need to contact the pediatric surgeons. But you don't delay giving antibiotics, so technically it's J, if that makes sense. But they won't do that to you because that's very harsh. But just to illustrate the point, it is technically the antibiotics, so you don't delay giving the antibiotics. Does that make sense? Correct. So it's Lennox-Gastaut syndrome, and that's because it's atonic-tonic seizures. So that the falling to the ground is during its atonic phase, and then when it's increased tone, that's the tonic phase in her arms. Delayed milestones are also common in this syndrome, and the 1 to 2 slow hertz spike waves with the paroxysms of fast activity. That's classic. Classic Lennox-Gastaut. The reason, sorry, someone's asking why is it not C? The reason it's a tonic atonic seizure syndrome, not just and then C is a just atonic. But good thinking and good pickup that you worked out that it was tonic atonic. So, yep. Oops, sorry. What have I done? Yep. Next one. Yep. So in this question, it's asking for the most likely diagnosis. I've got a few Bs, acoustic neuromas, which I'm sure you're probably thinking of from GP because you have to know that for GP as well. In kids, the most common tumor in the brain is medulloblastoma. So that's why that's the answer, because it's the most likely diagnosis, and it's that morning headaches with, and it also comes up it usually commonly arises in the posterior fossa, which is near the cerebellum. So it causes those sort of symptoms of ataxia, clumsiness, difficulty walking, things like that. Does that make sense? Cool. Someone's also asking what the antibiotics are for necrotizing enterocolitis. From memory, it's IV metronidazole, gentamicin, and vancomycin. Cool. Next one. How do you guys read these questions so quick? I swear, like it's G, very good. Febrile convulsions, secondary to otitis media. No need to go through that because I feel like we've gone through that multiple times. What would be the next step in management for this one? I'm getting a few A's and B's. Maybe tell me what you think the condition is. So what do you guys think is happening here? Sorry, lost my slides. Sorry. No, anyway. Oh, Oh my gosh. Sorry, guys. Cannot get it back up. All right. I think that's got it. Yeah. Well, oh, this is another question. Sorry, I don't know where the other one's gone. Sorry, we'll come back to that one. Maybe if you guys answer this one, and we'll come back to the other question. Sorry about that. Yep. So getting a few. Yep, cool. All right. So this one's a Sufi, and you can tell from this one that it's the reason it's a Sufi is because it's a young sort of adolescent male. This sort of description here about the percentiles tells you that he's perhaps a little bit overweight, which is a risk factor for a Sufi. And there's no X-ray here, but if there was, then yeah, you all worked it out anyway that it's a Sufi, and then so that's urgent orthopedic referral. What about this one? Yeah, everyone's saying D. Yep, so septic arthritis, so IV flucloxacillin is the definitive management. I'm sure at some point you probably would refer it to orthopedics, but it's asking for the definitive management there, so you do that. Oh, that's it. Sorry, I'll see if I can find that other question. I feel like medulloblastoma. Oh yeah, this one. That's not it. I don't know where that other one's gone. I'll repost the slides with the questions. Sorry about that. Okay, cool. Did anybody have any questions about any of that stuff that we went through today, or anything at all? Anything else you want to go through? Quickly recap. Oh, people asking about if rubella is itchy. Yeah, that's my bad. So it may or may not be itchy as per DermNet. So the management for DDH. Okay, so the management for DDH depends on the age of the child. So the way that I break it up is usually by age. So if the child is before if they're less than 6 months, usually the way that you manage that is with splinting. So with either some sort of like a Dennis Brownlow bar or a pelvic harness. Then the next sort of age range is 6 to 18 months, and that's closed reduction. So that's under anesthetic, but they move the hip back into they move the leg back into place without making any incisions. But then if the child is over 18 months and they still have like we talked about how they probably have that leg discrepancy, they might be walking on their toes to compensate for that. Then you'd probably have to then do open reduction, and that's under general anesthetic again, but it's an incision made and the leg is then placed back into its correct position. Does that make sense? Sweet. Cool. Anything else you guys wanted to recap? And if there are questions about other topics that I can't answer, I'm happy for you guys to either reach out to me or to message the speakers individually, whatever works, and I'm happy to pass on any questions. What was the answer for the externally rotated hip question? I think it was a Sufi. I will find that and I'll put that back up on the slides. I'll upload these questions anyway, so I'll be able to fix that. Sorry about that. But for your exam, I think at this point of the year as well, are your exams like next week? I think, yeah, next week, next 2 weeks more. 2 weeks more. Yeah, just like memorizing the buzzwords. and just sort of going through that is the best way to go about it. I think you don't have to rely entirely on buzzwords, but I think if you're desperate for some of the conditions, I think particularly the ones that I went through, like derm, ID, the MSK ones, if you can sort of get a gist of the questions based off of buzzwords, that'll be the bulk of it. For your cardio, resp, GI, heme, onc ones, maybe perhaps you need a little bit more study, but for these ones, I think you'll be able to get by with mainly buzz. People asking, oh, how are the questions compared to the past? These ones are a lot longer than the ones compared to past papers. So that's why I wrote them a bit longer, just in case you get like shafted a bit. But I think you got them all right anyway, so I think you guys will be fine. But they usually are pretty short. It'll be like 2 sentences, and then it'll want the answer. So they're not super involved. The other specialties though, they can be a bit longer and they take a bit of time. So I'd probably, depending on what your strengths are, I'd probably start with either the shorter one or the longer one on the women's. So like meaning the women's health, just so that you can get through it. But I definitely spent the bulk of my time on the women's health portion of the exam last year. Yeah. Feel free to head off, guys, if you don't have any more questions, but I'll just keep answering them as you send them through. The questions, how they'll appear is, yeah, they're split up. It'll, like on the platform thing, it'll say like questions 0 to 50, and it'll be like women's health, and then the second part will be children's health. Yeah, but the order of the questions will probably be randomized so that you can't copy. Not that you're going to be doing that anyway, because there's cameras watching you and the Zoom thing's watching you and everyone's watching you, so you're not going to be copying. But they do that anyway. They randomize the order of the questions, I think, but they don't mix the specialties. So you'll go through all of the GP questions, and then you'll get all of the psych questions for paper 1. And then for paper 2, you'll go through all of the women's health questions, and then you'll get all the GP questions. You can click through whichever ones you want whenever you want and move back and forth, but they're split up. So just so that it's a bit easier, because if not, it'd be annoying going from a PEDS question to a women's health question to a PEDS, so yeah, they do split them up. Yep, measles is just supportive management unless they're really well. I think for measles as well, you probably do want to give them the vaccine. Remember how we talked about the MMR vaccine if it's 72 hours, and IVIG if it's greater than, yeah, but the IVIG is if they're really unwell. Yeah, you don't just whack that onto everyone. Usually they will probably be unwell if they do have measles. You won't be asked too many questions like that. Like it's not just, they won't say like, oh, no management or supportive management. It'll be very specific because they're just trying to test if you know what to do for this disease, not can you work out if this child needs management for their measles, if that makes sense. How were last year's questions compared to the previous past papers? Pretty fair. Like they were pretty on par with how they were in the previous years. I know there's been and even I've had this feeling like going through the exams where it's been like, oh, in third year they suddenly switched up all the exams, and then last year was different again. But for PEDS, it was very much how the 5th years when I was in 4th year told me it was going to be. So it didn't change too much. The other specialties, yeah, it was a bit different, a bit harsh, a bit harder. But you've probably been prepared for that since the start of the year. Everyone knows that PEDS is supposed to be relatively straightforward, and I think it will be again this year. Were any specialties really different? Not that I was sort of really aware of. I think everybody said no, the prompt guidelines for Monash for women's health, and that's how it was. Wasn't too different. For GP, it had a big focus on investigations and interpreting investigations. Like they'd give you a panel of questions, a panel of blood or the results of a CMP, UECs, things like that, and then expect you to work out the diagnosis from there. Kind of like how you would if you were a real GP, I guess. But they weren't unfair questions; they were very fair. And then psych is as psych is. Like it was pretty straightforward, I guess. Pretty much like the past exam questions. Lots of medication side effects questions in addition to how would you how would you manage this, I'd say. Yeah, but straightforward. Yep. I guess they're all straightforward if you know the content. But no, I don't know. I won't lie, like women's health was, I certainly found that very challenging because I haven't got a very good memory. And it takes me a while to read everything. Any good resources for the psych drugs? Oh, the SciSum has a thing on their website that has like all of the medication side effects, kind of like buzzwords, but it goes through all of the known medications and their associated side effects, like aripiprazole for like prolactinemia, that kind of thing. That's just off the top of my head. Just like, like if that's what you mean by that question, and that would be, yeah, that would be a good resource. Yep, no worries. Cool. Will we all pass? Yeah, I'm sure you will. Asterisk, I'm not legally responsible for anything I say on this Zoom. Anything else? I really appreciate everyone coming along as well. I know it's like so close to exams and it's probably easier to watch the recording, but I really appreciate someone coming and the three of you keeping your cameras on, and you all win prizes for that. And I've also picked out other people's names for just messaging me things or picking up things that were wrong with the slides. Everyone gets a prize. You get, I see if I sound like Oprah now, but anyway. What was the answer to the riddle today? Oh, sorry. Yep, the doctor says that's enough out of you, because he took his appendix out and he says that's enough out of you. Oh. Yeah. Yeah. My mom always tells me I'll have a future career as a clown if I can't get through med school. Anyway, no, I didn't write that myself. Anyway, I'll let you guys go before I do any more damage to my reputation. That's already probably pretty poor. All right. See you guys. Thanks for coming. Good luck with your exams.